Good evening and Assalamu alaikum. My name is Dr. Tariq Elhad. I'm Senior Consultant Endocrinologist at Hamad Medical Corporation in Doha, Qatar. I chair the webinar committee of the Arab Thyroid Association. And on behalf of the association, I would like to welcome you today to the sixth series of the thyroid educational webinars, and actually it gives me great pleasure to welcome a sort of a fiesta of very distinguished speakers. We have two eminent speakers. We have Professor Bollard and Dr. John Ayuk. Both of them are from University Hospital of Birmingham in the United Kingdom. And we will also have a session on thyroid round, which encompass actually 4 interesting cases from around the Arab world. And I think with the first sort of talk, we are going to have great pleasure in welcoming a very distinguished speaker indeed, Professor Christine Pollard, who's Professor of Endocrinology at the Endocrine Department in the University Hospital, Birmingham. Dr. Bollard is a very well, actually, and revered figure in the world of thyroidology. She's a very well-known through her extensive research. She is having a wide spectrum research interest, spanning the whole spectrum of thyroid disorders, especially thyroid nodules, thyroid cancer, as well as she also actually runs quite extensive research in the endocrine disorders of pregnancy. She leads actually one of the most important NICE committee overlooking actually the thyroid disorders. And she has published widely, and she is a recipient of so many awards. Christine is going to present us the plenary session on the update in management of Graves' disease. Christine, the center stage is yours.
Thank you very much, Tariq, for that kind introduction. Good evening, everybody. I presume you can all see my slides, and this is now on the first slide. Just let me know if that's not the case. So I'm going to give an update on the management of Graves' hyperthyroidism. And essentially what I have are 2 cases, and then obviously we can't do any live audience polling here in this session, but essentially I put the cases as an illustration so that we can then have a discussion about them subsequently. So this is a 49-year-old female who presents with typical symptoms of hyperthyroidism. She is known to have hypertension on lisinopril, and her sister has a family history of cardiovascular disease, with her sister having an MI aged 55 a few years ago. She has a small diffuse goiter, a fast pulse, a tremor. Her palms are moist to touch, and she has bilateral lid retraction, and you can see a picture of her there. You can see that she has an undetectable serum TSH and raised free T3 and free T4 concentrations. I'm not sure if these are the same units that you use, but I've given the normal reference ranges there. And so my question is, what is the most appropriate next test? So Graves' disease is an autoimmune disorder, as we all know, caused by long-acting stimulating TSH receptor antibodies. I show here a picture of Robert Graves, who described Graves' disease so many years ago. And this has a population prevalence of 1 to 1.5%. It has a peak incidence, particularly in women between 30 and 60 years, and is the most common etiology of thyrotoxicosis in iodine replete areas. About 80% of Graves' disease is determined by genetic factors, and 20% are environmental factors, Factors implicated include smoking, viral infections. Stress has also been implicated. It is 5 times more common in women than in men. And here, this cartoon here depicts the pathogenesis of Graves' disease. You can see that you have these long-acting stimulating antibodies that attach to TSH receptors on thyroid follicular cells, resulting in overproduction of thyroid hormones. And as a consequence of negative feedback, TSH is undetectable. I'm sure this audience does not need explaining around this. Because we have thyroid receptors in virtually every organ in our body, symptoms can be quite varied. However, as is illustrated on this slide here, often it is the cardiovascular and gastrointestinal symptoms that predominate. So patients often present with palpitation, weight loss despite an increased appetite, and then maybe tachycardic, and weight loss may also be evident on clinical signs. But of course, the symptoms can be quite widely varied and are very much age dependent. So in older people, often you have fewer symptoms. We also have to bear in mind that there are a number of extrathyroidal manifestations caused by these antibodies also attaching to other receptors, such as in the soft tissues around the eyes and the soft tissues around the shins. So it is estimated that about 95% of patients present with hyperthyroidism and a diffuse goiter. Textbooks tell us that about 50% of patients have thyroid ophthalmopathy. In clinical practice, that is probably only clinically evident ophthalmopathy at presentation is around 20%, with severe ophthalmopathy in about 5%. However, if you were to do an orbital MRI scan, you would probably identify Graves' eye disease in about 75% of patients. What's also depicted here is the predibial myxedema and the acropathy that you may get. So it is really important, and I cannot stress this enough. This is also one of the main messages that I try to bring home in the NICE guidelines, is that you need to differentiate thyrotoxicosis with and without hyperthyroidism. So you do need to distinguish Graves' disease from other conditions such as thyroiditis, which are often self-limiting and do not require treatment. In order to do this, we have 3 main tools: measurement of TSH receptor antibodies, an isotope uptake scan, or you can measure thyroidal flow on an ultrasound. So these are typical pictures here of isotope scans. So you can see diffuse uptake in Graves' disease, more patchy uptake with increased uptake in these two toxic nodules, and reduced uptake in the remainder of the thyroid gland. And then this is a picture of a patient with thyroiditis where there is no uptake, because essentially what you have is a diseased thyroid gland with cells that are just leaking thyroid hormones and are unable to concentrate the radioisotope. Thyroidal flow on an ultrasound can also be helpful. Here, a typical patient with Graves' disease, where you can see significantly increased flow. And then this is a picture of a patient with toxic nodular, sort of a multinodular goiter. However, it can be difficult to distinguish thyroiditis from Graves' disease on ultrasound. These are the guidelines from the European Thyroid Association, where again, we very much depend on biochemistry. So your best marker of your thyroid status is a TSH measurement. If that is low or suppressed, you then measure circulating thyroid hormones, which help you identify the different forms of thyrotoxicosis. So my first approach, and the answer to the question of the case that I presented, would be, in the first instance, you measure TSH receptor antibodies. If they are positive, then that confirms Graves' disease. If they are negative, then you have to look for other causes of hyperthyroidism. And what my protocol in my hospital and the NICE guidelines recommend is if TSH receptor antibodies are negative, that you perform an isotope uptake scan. If you're in Europe, then you would probably also do an ultrasound, but the NICE guidelines actually recommend against this because we find too many incidental thyroid nodules, which can then may be difficult to deal with. Treatment of hyperthyroidism hasn't actually changed that much in the last 60, 70 years. The 3 mainstays of treatment still remain anti-thyroid drugs, radioiodine, or surgery. And advantages and disadvantages are given on this slide here. Advantages in green, disadvantages in red. So anti-thyroid drugs are non-invasive and cheap drugs with a low risk of developing permanent hypothyroidism. Of course, this requires the patient taking the medication. They are not devoid of side effects, and I will come back to this. And we know that only about 50%, and that's an optimistic estimate, of patients will be cured even following a prolonged course. Radioiodine is very effective. 90% of patients are cured with one capsule, can be given as an outpatient, and is easy to give. However, patients have to comply with radiation protection, and there is a risk of developing permanent hypothyroidism. And then surgery, especially in an emergency situation, is a very effective cure, which results in rapid control, but of course is much more invasive and is associated with a number of long-term potential side effects. And so again, what the NICE guidelines, what the ATA guidelines recommend is that at presentation, when the patient presents to you with Graves' disease, once you've confirmed that the diagnosis is Graves' disease, that you have a discussion regarding the various treatment options and that all risks and benefits are discussed. Depending on the patient's situation, one or another option may be favored. For example, someone who's trying to become pregnant in the near future, probably you wouldn't go for radioactive iodine. If patients have a large compressive goiter, then surgery may be the preferred option. And in order to control patients' symptoms, consider the use of beta blockers. And indeed, beta blockers are very, very good drugs to control patients' symptoms. When you look at how these various treatment options are used across the world, so if I take you to the right-hand side of this slide here first, so in 1991, it appeared that about 70% of patients presenting with a new diagnosis of Graves' disease would be treated preferentially with radioactive iodine. When that survey was repeated in 2011, that had decreased slightly. In Europe, the radioiodine is less favored, and you can see that even between 91 and 2011, that went down. I think you might be interested in the Middle East figures, and this is from the most recent survey in 2011. So this is an ATA survey where you can see that as a first-line option in the Middle East, 33%, so about a third of patients would be recommended to have radioiodine, and the remainder anti-thyroid drugs. The data from North America and Europe, again, shown here, but they're also shown in this graph. So how do we give anti-thyroid drugs? Well, you can either give a block-replace regime or you can give a titration regimen. This was reviewed by the NICE guidelines, but also another number of systematic reviews have looked at it. And actually, there is no difference in relapse rates, whichever regimen you prefer. Patients who go on block replace because they're maintained on higher doses of anti-thyroid drugs may have more side effects, and there is clear evidence that the side effects of anti-thyroid drugs are dose related, and therefore there may be a higher participant dropout rate. Particular predictors of poor remission, and we haven't got very good predictors, but we know that when men get Graves' disease, it's difficult to cure them. Those patients with large goiters, those patients with high levels of TSH receptor antibodies, and those patients who have very severe disease at diagnosis, so a higher free T4 concentration. So I very much was trained using a titration regime and rarely use a block replace regime. However, when COVID came about, I actually wrote the guidelines for management of this during the pandemic, and a block replace regimen can be a preferred option, especially when patients have less access to regular blood testing and when we try and keep patients stable for longer periods of time, because you often have to check less blood tests in patients who are on a block replace regimen, and an algorithm for how to manage patients during a pandemic when there is less access to medical care and to blood testing is given here, and you can read further about that in the paper. The reference is given at the bottom there. So what about side effects? Well, so the two main drugs, as you know, that we use are carbimazole in the UK, metimazole in the rest of the world, carbimazole being the precursor of metimazole, and propyltyrosine. So both of them are associated with a rare risk of agranulocytosis, occurs in 0.2 to 0.5%, no difference between either of these drugs. And I'll come back to discuss each of these side effects in turn. Carbimazole has been linked to a higher teratogenic risk, and my second case is a case in pregnancy, when I will come back to that. And more recently, carbimazole has also been linked to pancreatitis, and certainly in the UK, there is an MHRA warning that we have to be careful in patients with a history of pancreatitis. I'm sure everyone is aware that propyltyrosine has had a lot of bad press in relation to liver failure. So these are major side effects. They are rare. Common minor side effects are common, so I tell all patients that they may get a rash, they may get some joint pains, and they may feel a bit sick with it. And generally, if they stick with the medication, these side effects go away. Talking about agranulocytosis, and for a long time we thought that agranulocytosis was not dose linked. We then had a nice study from Japan showing that it is indeed dose linked, and you can see that patients who were given 15 milligrams daily of metimazole versus those who were given 30 milligrams daily had less agranulocytosis and less neutropenia. Usually this occurs in the first 90 days of treatment, and it is unclear whether this is a direct toxic effect of the drug or whether there is actually an immune targeting of the granulocyte lineage. So the recommendation is that you should not routinely keep checking full blood counts in patients because there is no evidence that this results in better outcomes, but you should certainly do a full blood count prior to starting them because it's always nice to know that the patient has a normal neutrophil count before you start. Beware that agranulocytosis is defined as a neutrophil count at less than 0.5, whereas neutropenia is a granulocyte count less than 1. Because I often get calls from GPs who say, well, the patient's neutrophil count has dropped from 2.1 to 1.9. What should I do? Well, that is not agranulocytosis or neutropenia, and the patient should just continue on the drug. Liver failure, this was the landmark paper, so this was in a pediatric population. This here represents a sort of a side effect score. I can't remember the full details of it, but essentially what this shows was that there was a significantly increased risk of liver transplantation in young people having propylthiouracil, which was not present with metimazole. Many patients, you have to be aware that many patients have abnormal liver function when they present with thyrotoxicosis. Often with PTU, you get a hepatic picture, whereas it is more a cholestatic picture with metimazole. Between 1990 and 2007, there were up to 3 liver transplants reported annually in the US. And whereas in Taiwan and China, actually, there was no difference between PTU and metimazole with regards to liver toxicity. However, in children, PTU is definitely contraindicated, and in adults, we generally reserve this for pregnancy. And again, I will come back to this. Again, I check a baseline liver function in all my patients who have thyrotoxicosis. Looking then at pancreatitis, so this was first identified in the Danish database, where you can see a large number of, so the Danes have very nice, well-documented databases. You can see a large number of patients were studied, and you can see that there was a significant number of people that were admitted with acute pancreatitis, and the odds ratio of acute pancreatitis was significantly higher in those having metimazole compared to those getting propylthiouracil. However, when this was subsequently looked at in the Taiwan database, there was no association found. Nonetheless, as I've said, there is a particular warning out in the UK. I have never seen a case of anti-thyroid drug-induced pancreatitis. How long do we continue medication for? Well, so there are a number of studies. In Europe, generally, people give longer durations of treatment. When we reviewed this extensively for the NICE guidelines, there was no benefit from continuing after 18 months. What I find really useful in managing these patients is measuring their TSH receptor antibodies before I stop treatment, because as this graph here illustrates, when patients have low levels of TSH receptor antibodies after 19 months, the risk of relapse is about 30%, and that is much, much higher when they still have significant levels of antibodies. And a similar study here from Italy, where again, you can see once antibody levels go above a certain threshold here, in this case above 2, the risk of relapse is significantly higher. So I do use TRAB antibodies as a further tool here. So the European Thyroid Association guidelines, like I said, so anti-thyroid drugs are much more favored in Europe than they would be in the UK, in the US, and I think when compared with the Middle East. But so they suggest that patients with untreated Graves' disease have metimazole, unless there is a particular reason to give definitive treatment options with surgery or radioactive iodine. What they suggest is once they've had an 18-month course, if they still have positive antibodies, that you may either consider continuing for a further 12 months or that you give a definitive treatment. I think I am more forceful in recommending definitive treatments early on. That is also what the NICE guidelines recommend, but certainly in patients who have persistent hyperthyroidism or significantly raised levels of TRAb after 18 months, I lean on them much harder to have a definitive treatment option. What about quality of life? And so there have been a number of studies that have looked at this. So we know that patients who have anti-thyroid drugs may well need definitive treatment. So what this study here, so this was using the TIPRO questionnaire, and you can see essentially patients' quality of life. So the tighter this line is here, the less effects on quality of life patients have. So you can see that all patients with hyperthyroidism have significant reduced quality of life, but that seemed to be particularly pronounced in patients who had radioactive iodine, as is identified here. There have been a number of other studies that actually showed no difference between patients having radioiodine surgery or anti-thyroid drugs. So I think the jury is still out on this. And of course, what often patients ask us is, why are we not treating the underlying condition here? Because we now have very good immunological treatments for so many conditions, rheumatoid conditions, cancers. We use monoclonal antibodies for so many things, but none of the treatment options we have for Graves' disease actually address the underlying immune problem. So this was a study that I was involved in, led by Simon Pierce, where 12 participants with mild Graves' disease were given a particular antibody that was targeted at 2 TSH receptor peptides. And this, so initial data from this, I won't go into too much detail here, but initial data from this, and this was a phase 1 first-in-man study, showed that actually circulating thyroid hormone levels in the majority of patients came down significantly with this peptide. Further studies of this are still ongoing. There have also been recently some studies with Rituximab in children. So unfortunately, none of the immunological treatments have consistently shown a benefit. There are ongoing studies, and I think that may be something for the future, but certainly not commonplace to immunologically treat these conditions. Moving on then to my second case. So this is a 32-year-old lady who is pregnant with twins, 6 weeks pregnant. She's otherwise fit and well. There is autoimmune hypothyroidism in her sister, and she has been admitted with severe vomiting and dehydration. You can see that she has a low TSH and a raised free T4 and clinical features consistent with thyrotoxicosis. And the question is, how should she be treated? So I think this is likely to be a case of gestational transient thyrotoxicosis. This is a patient who's pregnant with twins, is likely to have high levels of HCG, and 90% of newly presenting thyrotoxicosis in pregnancy is GTT. This is a self-limiting condition which usually resolves with normalization of thyroid function. It's not associated with adverse outcomes and is often linked to hyperemesis. Often patients, so in order to distinguish, you can ask the patient if they had symptoms before they presented, because if they did not have thyroid symptoms before they presented, it is highly unlikely to be Graves' disease. Patients with Graves' disease often will have a goiter and eye signs, which is on many occasions not present in GTT. And if you want to do some laboratory tests to distinguish between them, a free T3 will often be normal in GTT and will be raised in Graves'. And of course, TSH receptor antibodies are a very useful tool here. Looking then at how we treat, so if this patient had Graves' disease and how we treat Graves' disease in pregnancy, so what we need to bear in mind here is the potential teratogenicity of anti-thyroid drugs. And so these are the original data from Japan here, looking at patients who were treated with metimazole and propylthiouracil. What is given on the y-axis here is fetal abnormalities, and you can see that this was significantly higher with metimazole. So that brought around the recommendation to, in the patients who are trying to become pregnant, so before pregnancy and in the first trimester of pregnancy, to preferentially use PTU. We've then had data from the Danish database again, which actually showed that both in patients with carbimazole and patients treated with PTU, there is an increased risk of adverse outcomes. This was the adjusted odds ratio was slightly higher in carbimazole, but it is certainly not absent in patients treated with PTU. The difference is that patients treated with metimazole often have a syndrome with various abnormalities, many of which may not be easily correctable. So you can get choanal atresia, you can get aplasia cutis, and you can get an omphalocele. Often this is all part of a syndrome, whereas in PTU it's often a single defect, such as a preauricular cyst or a hydronephrosis, so a singular and less severe defect. The best data we have on anti-thyroid drugs and congenital risks come from this large database published in 2018 from Korea. You can see a very large, nearly 3 million pregnancies with a very large number of live births. You can see nearly 13,000 pregnancies were exposed to anti-thyroid drugs. And so the risk overall of birth defects in patients exposed to anti-thyroid drugs was significantly higher compared to those who weren't, with an odds ratio of 1.19. This was particularly pronounced from metimazole, but importantly, what this showed was that if you give patients metimazole and then change them to propylthiouracil during pregnancy, the increased risk of fetal abnormalities still remains present. A further very important point here is that this was very much dose dependent. So we should always aim for the lowest possible dose of anti-thyroid drugs during pregnancy. So how do I manage this? Well, pre-pregnancy, if I know the patient is going to try for a pregnancy, I change the patient to propylthiouracil. Now, of course, I work in an area where only about 50% of pregnancies are planned. If the patient presents in the first trimester, I often keep them on the same drug. So if they've already had 10 weeks of exposure to carbimazole, I don't change it. If I've changed the patient to PTU and they still need anti-thyroid drugs in the second and third trimester, I often change to carbimazole. You should not use a block and replace regimen in pregnancy because anti-thyroid drugs will preferentially cross the placenta and you may well make the baby hypothyroid even when the mother is euthyroid. Always use the lowest possible dose. Often Graves' disease gets better in pregnancy and we can stop the medication from the mid-second trimester. And I always aim to keep the free T4 in the upper half of the normal range. These are patients who in my practice have regular 2 to 6, well, probably 2 to 4 weekly thyroid function tests, certainly when they're actively being treated using trimester-specific reference ranges. Measurement of TSH receptor antibodies is really important in these patients. And when we discuss treatment in a patient who may become pregnant in the next few years, we need to bear in mind that TSH receptor antibodies actually shoot up after radioactive iodine. So something further to consider in a woman of childbearing age, which often is the case in a patient with Graves' disease, if they're going to have radioactive iodine. You can see here in patients treated these are data from Denmark again, patients treated with anti-thyroid drugs, with surgery and with radioactive iodine. So the level of TSH receptor antibodies shoots up significantly after radioactive iodine and actually for many, many years may stay raised. And I have treated a number of patients who've actually been made hypothyroid by radioiodine, but who still have positive TSH receptor antibodies, whose fetus gets fetal Graves' disease, and this can be very, very difficult to manage. So we advise following radioiodine not to become pregnant for 6 months, both for radiation protection, but also because of these antibodies. However, I think we need to discuss with patients that antibody levels may well remain very high. So how do we manage Graves' disease? Well, we need to discuss with the patient risks of hyper and hypothyroidism, and best outcomes really are by keeping the patient as euthyroid as possible, because both over and underactivity of the thyroid gland are associated with significant increased risks. Signs of fetal Graves' disease are fetal tachycardia, growth restriction, and a fetal goiter that, of course, is very difficult to identify on a fetal ultrasound. I measure TSH receptor antibodies in everyone who presents to me at the first appointment during pregnancy, whether they are actively being treated or not. So anyone who's ever had Graves' disease has a TSH receptor antibody measurement. If that is raised, I repeat it at 20 weeks, because at 20 weeks, I will then decide how often patients need regular growth scanning and how often we need to auscultate the heart. And so it's what this graph here illustrates are outcomes associated to TSH receptor antibody levels in patients. So you can see that the risk of the patient, of the baby being born with hyperthyroidism is significantly higher when TSH receptor antibodies are more than 3 times the upper limit of normal. So regular TSH receptor antibody testing, doing fetal ultrasound when needed, and regular fetal heart rate auscultation result in better outcomes here. I think I might be out of time here, so I will not dwell on the conclusions here. These slides will be available for you. You can read them, and I thank you very much for your attention.
Thank you very much, Professor Pollard, for a very clear and crisp and very fantastic presentation. So I think I will, before I ask one question, I could see that there is one question. I will let my colleague, Dr. Samir Al-Isa, actually to, read it out. One of the audience.
Sure. Good evening, everybody. My name is Samir Al-Isa. I'm delighted to be co-hosting tonight's webinar with Dr. Tariq. I'm very delighted. Dr. Tariq, do you want to do the questions at the end, or you want to deliver the question for Dr. Pollard right now?
Yeah, I think, right, we are having 1 minute. I think we'll probably have many questions because as we go with 4 cases as well as second presentation, we will have quite many questions. So I could see that there is only one question. She can handle it quickly. And I have a quick question, and then we can go over to John.
Sure. Dr. Pollard, there's a question that mentions here patient with, first of all, thank you for the excellent presentation. The question says that there's a patient with suppressed TSH. They do have patchy thyroid uptake, but the thyroid uptake in upper normal. What would be the diagnosis? It could be multiple toxic thyroid nodules, and how would you treat that?
Okay, thank you for that question. And so this is, of course, a very, because it's all well and good for me to say, check TSH receptor antibodies. If they're negative, do an uptake scan, and you will have your answer. As this case illustrates, often an uptake scan just shows patchy heterogeneous uptake, and you know further. So what current guidelines would recommend, if TSH is fully undetectable, and certainly when T3 and or T4 are raised, I would treat that ideally with radioactive iodine. If the patient wants surgery and we think there are multiple toxic nodules, possibly bilaterally, then they may need a total thyroidectomy. If we have evidence that it's only on one side that they have toxic nodules, then a hemithyroidectomy may suffice. But so if TSH is less than 0.1, with normal T3 and T4, I would discuss treatment certainly in someone aged over 65, someone aged under 65 if they have cardiovascular disease, osteoporosis or symptoms. If free T3 and free T4 are raised and or free T3, sorry, either of those or both are raised, then I would treat ideally with radioactive iodine. I hope that's answered the question.
Yes, thank you so much.
I think Samir, Samir, you go ahead and introduce John.
Sure.
And then we will have ample question because just would like to stick to time. And I will let you to introduce my dear colleague and friend, John Ayok.
Thank you, Dr. Tariq. Very delighted to present our next speaker, Dr. John Ayok. He's a consultant endocrinologist and the pituitary service lead at the University Hospital in Birmingham. He was trained in endocrinology at the West Midlands and was awarded his doctorate in medicine following a research fellowship in endocrinology at the University of Birmingham. His research interests includes in the pathogenesis management outcomes of endocrine tumors. He's author of many papers, also regular guest in writing consensus guidelines. He's also honorary senior lecturer at the University of Birmingham, past chair of the UK Acromegaly Register Screening Committee, and past chair of the Program Organizing Committee of the UK and Ireland Neuroendocrine Tumor Society. Very delighted to listen today for his keynote lecture about the challenges of tertiary hyperparathyroidism. Dr. Ayok, presentation is yours.
Thank you. So I hope you can all see my slides now. And I'd like to start by thanking you, Tamer, for the kind introduction, and also thanking Tariq for actually inviting me to do this talk. So I'm aware that this is the Arab Thyroid Association, but I won't be talking about the thyroid. I will be talking about the parathyroids, and more specifically, the challenges in the management of tertiary hyperparathyroidism. So those are my declarations. And so I'd just like us to start by just reminding ourselves a little bit about calcium homeostasis. And so if we start at the top, you all know the parathyroid glands are 4 little glands which usually are situated behind each pole of the thyroid gland. And what they do is they respond to any stimulus which, stimulus which is usually a drop in serum calcium levels by secreting parathyroid hormone, which then goes to the end organs, mainly the kidneys and the bone. In the kidneys, what parathyroid hormone does is it increases calcium reabsorption, thereby increasing the amount of circulating calcium, reduces phosphate reabsorption, so increases excretion of phosphate, and also activates 25-hydroxyvitamin D to 1,25-hydroxyvitamin D. Now, the activated vitamin D and parathyroid hormone both go to the bones and have similar effects in that they release calcium from the bones into the extracellular fluid, so into serum, and thereby increase the blood calcium levels. And vitamin D also enhances calcium absorption from the small bowel. And so if we talk about tertiary hyperparathyroidism, it means there must be a primary and there must be a secondary. So just to touch briefly on those, you all know primary hyperparathyroidism, one of the most common endocrine conditions, and is usually caused in most cases by one benign parathyroid adenoma, which secretes excess amounts of parathyroid hormone and does not respond to the usual negative feedback which would be triggered by the high calcium levels in the blood. And so you get high parathyroid hormone levels, high calcium levels, and because of the impact of parathyroid on phosphate excretion in the kidneys, you tend to get low phosphate levels. And obviously, you're all aware of the symptoms which this can cause. And in the UK, we have a mnemonic we use, which I'm sure many of you will have used and read in medical textbooks, of stoned bones, abdominal moans, and abdominal groans and psychic moans. So obviously kidney stones, the impact on bones, osteomalacia, Brown's tumors, and so on, abdominal pain, both through gastritis and also through things like constipation, and psychic moans because of the neurocognitive effects that hypercalcemia can have. Secondary hyperparathyroidism is actually a normal physiological response to low calcium levels, and it occurs in 2 settings in general. First is with vitamin D deficiency, which is something which all of you guys in the sunshine don't have to worry about too much, but someone like me with dark skin in the Nordic climates does have to worry about, because we have so little sunshine, and what little sunshine there is, my skin blocks off. So it's very common for people from ethnic minority backgrounds in the UK to have vitamin D deficiency. And I'm sure, Tariq, that was probably one of the things you were fleeing when you left here to go back to warmer climes. So what happens, obviously, as you all know, we get most of our vitamin D from sunlight, a little bit from diet, and in the liver, it's hydroxylated to 25-hydroxylated vitamin D, but that is inactive. And it's in the kidneys that it gets hydroxylated to 1,25-hydroxyvitamin D. And the 1,25-hydroxyvitamin D does what we've mentioned before, so it mobilizes calcium from the bones and also leads to increased absorption of calcium. So if you have got vitamin D deficiency for whatever reason, then what tends to happen is you don't have enough 125 or activated vitamin D, you don't mobilize enough calcium, don't absorb enough calcium from the gut, and therefore vitamin D levels, your calcium levels are low. And what happens then? As a normal physiological response, through the negative feedback mechanism, the parathyroid glands will sense this and will secrete high amounts of parathyroid hormone in an attempt to get you to absorb more calcium into the intravascular system. Now, the second cause of secondary hyperparathyroidism is chronic kidney disease. And this is what most of my talk today will be focused on. Now, what happens when you've got chronic kidney disease? In the presence of chronic kidney disease, first of all, what happens is your phosphate excretion from the renal tubules decreases, and so you get hyperphosphatemia, so high levels of phosphate in the blood. You also get high levels of fibroblast growth factor 23 in the blood, and all of these have quite significant effects. So in the presence of kidney disease, because you don't have enough viable kidney tissue to activate vitamin D, so to complete the 1-hydroxylase phase of manufacturing active vitamin D, you tend to have vitamin D deficiency. What does that do? That leads to hypocalcemia. The hypocalcemia itself triggers, through the negative feedback response, increase in parathyroid hormone, as we've mentioned earlier. Not only does that happen, but also hyperphosphatemia. So the high phosphate levels in the blood do the same thing. So they also trigger hyperparathyroidism. Again, this is secondary hyperparathyroidism. It is entirely normal. It is the parathyroid glands doing what they are meant to do. The problem is, obviously, with chronic kidney disease, it's often a long-term issue, and patients will progress with their chronic kidney disease to end-stage renal failure, will then go on dialysis, if appropriate, will then go on a transplant list, and then we'll have to wait for a kidney transplant for quite some time. So unfortunately, whereas with primary hyperparathyroidism, usually you have an operation, take out the adenoma, everything's sorted. With vitamin D deficiency, causing secondary hyperparathyroidism, you give the patient vitamin D supplements, that sorts the problem out. With chronic kidney disease, it's a much more difficult issue to deal with. And there's no easy way to deal with it. And so what is tertiary hyperparathyroidism? Now that's the first challenge, actually defining tertiary hyperparathyroidism. So tertiary hyperparathyroidism tends to occur when excess parathyroid hormone is secreted by the parathyroid glands, usually after long-standing secondary hyperparathyroidism. So what happens is, because of the continuous stimulus on the parathyroid glands through the hypocalcemia, first of all, you start off with hyperplasia of the parathyroid glands. So like I said, this generally occurs in the context of long-standing chronic kidney disease. But like I said, the definition of tertiary hyperparathyroidism can be controversial. So there are some authorities who will say that you can only define it as tertiary hyperparathyroidism if the patient has had a successful kidney transplant, the kidneys are working properly, and the disease still persists. However, others will say, if you've got a patient who has not yet had a transplant, has gone from having secondary hyperparathyroidism to developing hypercalcemia, you stop the supplements, they have persistent hypercalcemia, then you're already in the realms of tertiary hyperparathyroidism. You don't have to wait until they have their transplant before you can define this as tertiary hyperparathyroidism. And so, as I mentioned earlier, the pathophysiology behind this is you get prolonged stimulation of the parathyroid cells, which initially results in diffuse hyperplasia of the parathyroid cells. Now, this is still the normal phase. And this is the phase where if you correct the problem, then this all goes away. The parathyroid cells will return to normal. But what happens is the longer they stay, they have this stimulus to hyperplasia, then eventually they go from just being diffuse, it goes from being diffuse hyperplasia to actually being nodular hyperplasia. Now, once you start getting the nodules, that's when you're running into trouble, because you think, that's the point at which you're getting this conversion, you're getting into irreversible territory. And that's the stage at which, in many cases, patients with secondary hyperparathyroidism due to kidney disease will need to undergo surgery. This polyclonal hyperplasia usually affects all 4 glands. So these patients will generally, if they require surgery, will have total thyroidectomy. All 4 glands will be taken out. But what then happens is, with the continued stimulus, and the mechanism is not quite well understood, but at some point, this polyclonal nodular hyperplasia can turn into monoclonal parathyroid adenomas. So it goes into, you go from hyperplasia to actually developing an adenoma, as you would with primary hyperparathyroidism. And this, in many cases, single, but in some cases, it can be, you can have more than one monoclonal adenoma. Now then, in general, in patients who have end-stage kidney disease, the ultimate aim is for them to undergo kidney transplant. And those who are lucky enough to have a transplant will undergo certain changes. So there are things which will correct themselves. So once they've got a functioning kidney, then they get increased renal phosphate excretion. So if you remember, one of the things which happens with chronic kidney disease is phosphate retention. And that's one of the factors which stimulates parathyroid hyperplasia. So if the kidneys are working again, they've had a transplant, the kidneys are working, you can get rid of that excess phosphate, and within 12 months, the phosphate levels will tend to return to normal, sort of within normal range. Having said that, in 5 to 6%, patients will actually develop hypophosphatemia. You also get decrease of the FGF23. Again, generally around a year, it starts dropping a few weeks after transplant and tends to normalize around a year post-transplant. And again, what that does is it takes away that influence of, because what the FGF23 does is it also stops the hydroxylation. So it also stops formation of activated vitamin D. Now, unfortunately though, even in patients who have successful kidney transplants, there will be a proportion, and that, depending on which studies you look at, it ranges somewhere between 17 and 50% of patients who will have persistent hyperparathyroidism and hypercalcemia. And this is when, what is truly defined as tertiary hyperparathyroidism. Like I said, the range you can see there is quite broad, between 17 and 50%, but it's thought that probably it happens in about a quarter of patients, so about 25% of patients. So there are a number of risk factors. So there are factors which can make you think, even before patients undergo their transplantation, their kidney transplantation, which would set them already out at a level of risk for having persistent hyperparathyroidism, i.e. tertiary hyperparathyroidism, after their kidney transplant. So one is the actual absolute levels of parathyroid hormone and calcium that they have pre-transplant. So the higher your parathyroid and calcium levels are, the higher the chances that even after transplant, you will have persistent tertiary hyperparathyroidism. And not only does it predict whether you will have tertiary hyperparathyroidism or not, it also predicts the severity of the tertiary hyperparathyroidism. So again, the higher your parathyroid hormone levels and calcium levels are, the more likely it is that you will have severe tertiary hyperparathyroidism post kidney transplant. Also, the duration you've had end-stage renal failure, reflected by how long you've been on dialysis, also plays a part. And that's only natural, because obviously the longer you're on dialysis means the longer you've had all of these stimuli to the parathyroid glands, which means it's more, there've been more time for you to go from the diffuse hyperplasia to nodular hyperplasia to monoclonal adenoma. Patients who've had nodular hyperplasia on the parathyroid glands, so it's not, they don't just, if they just have the diffuse hyperplasia, in most cases, you will expect that post-transplant, everything will return to normal. But if they've already moved to the stage of nodular hyperplasia, there's a higher risk of them having persistent tertiary hyperparathyroidism after kidney transplant. And also long duration of calcimimetic treatment. So now, as you may know, there is a treatment, or there are medical treatments we can use in patients with secondary hyperparathyroidism due to chronic kidney disease. And these are calcimimetics. The one we tend to use in the UK is Teraparatide. And what this does is it lowers calcium and to some degree parathyroid hormone levels. So this is something which has only been available in the last 15 years or so. Before, all of these patients had to undergo surgery. Now, many of them will be treated with these calcimimetic drugs, and that will spare them from having to have parathyroid surgery. Again, if you've been on these drugs for a long time, I suppose it reflects the fact that you've had, chronic kidney disease for a long time, and that again is reflected in the increased risk of having tertiary hyperparathyroidism after transplant. How does tertiary hyperparathyroidism manifest clinically? Now, first of all, it will manifest in a very similar way to any form of hyperparathyroidism, to primary hyperparathyroidism or any form of hypercalcemia. So what we talked about before, the stones, bones, groans, moans, all of those will be a part of tertiary hyperparathyroidism as well. But in addition, because of the chronic kidney disease, there are further clinical aspects which are quite specific to these patients with chronic kidney disease and who have or have not undergone renal transplant. So, for example, in addition to everything else, these patients are at risk of worsening of renal osteodystrophy. So renal osteodystrophy, as you know, is bone disease which is particular to patients who have end-stage kidney disease or who've got kidney disease. And it's generally characterized by the fact that these patients have vitamin D deficiency, so they have problems with mineralization. And they've also got low bone mineral density, so increased rates of fractures. And again, the high phosphate levels and high parathyroid hormone levels, again, have an impact on the bone density. Graft outcomes, this is also an issue in patients who've undergone their parathyroid, who've undergone kidney transplant but have persistent tertiary hyperparathyroidism. And this is because the hypercalcemia and high levels of PTH can cause vasoconstriction and tubulointestinal calcification, which means it affects the kidney graft, the vasculature of the kidney graft, and can even lead to graft loss. So it can actually cause these patients to lose their transplant kidneys. And finally, the tertiary hyperparathyroidism is also significantly worsens cardiovascular outcomes. As you know, patients with chronic kidney disease, what most of them will die of is cardiovascular disease. And so if on top of this cardiovascular risk, you add the risk, the added on risk from tertiary hyperparathyroidism, it increases the risk of morbidity and mortality from vascular events in this cohort of patients. So not an easy cohort of patients to deal with. And when you're dealing with this issue, you have to manage them not just from the point of view as an endocrinologist managing their calcium and their parathyroid levels, but you also have to think about their, what's happening with their bones, what's happening cardiovascularly, what's happening with their graft. And to that effect, with our metabolic bone disease service, which sits within endocrinology, we run joint MDT clinics, multidisciplinary team clinics, with our renal colleagues dealing with some of these patients, because quite often the way we would manage these patients, either in our patients with metabolic bone disease, either just patients with hyperparathyroidism, or patients with things like osteoporosis. A lot of the management we do for those straightforward patients, we cannot necessarily do for patients with renal osteodystrophy and tertiary hyperparathyroidism. So it does take a lot of brain power sitting there with the renal physiologist working out what we can and can't do to manage these patients' conditions. So this just gives you an outline of some of the managements. As you can see, this is not focused purely on the tertiary hyperparathyroidism, but on the management of these patients as a whole, their tertiary hyperparathyroidism and their renal osteodystrophy and cardiovascular risk as such. So certainly, even in these patients, although we know the patients with chronic kidney disease cannot make activated vitamin D, it is still important to replace their 25-hydroxyvitamin D, because that does have other direct effects, for example, on musculature, on vasculature, which, even if they don't, it's not being used as substrate to make active vitamin D, which focuses mainly on increasing your calcium. If the patients do have secondary hyperparathyroidism and have low calcium, then obviously you use vitamin D analogs. If they've got hyperparathyroidism, you can use the calcimimetics. Thinking about their bone disease, sometimes we do use bisphosphonates in these patients, but obviously we need to be careful. As you know, for most bisphosphonates, you need to have a creatinine clearance of at least 35 to 40 mils per minute to use the drug. So we do sometimes come up with, in discussion with our renal physician colleagues, with sort of inventive ways to treat these patients. So we may give them, half the dose of a bisphosphonate, or give it, rather than giving it weekly, we'll tell them to take it monthly. Or, if we're giving them an intravenous or something like denosumab, we'll give half the dose rather than the full dose, just because we need to be aware of the fact that they've got kidney disease. So the other treatment, the treatment for patients with tertiary hyperparathyroidism, and this is the main treatment, is surgery. And this is when you've got patients with tertiary hyperparathyroidism, which is not controlled with medication, or they've got increased alkaline phosphatase levels, which mean they've got very high bone turnover and are at risk of fractures and other bone complications, or have other long-term complications of the high calcium and parathyroid hormones, like kidney stones, bone pain, and so on. In these patients, obviously, we need to do something, and the treatment of choice is parathyroidectomy. Now, having said that, once you say, okay, we've decided, made a decision, this patient needs parathyroidectomy, that is not the end of the story, unfortunately, because the question then arises, what sort of parathyroidectomy do they need? Now, like I said earlier, we do know that parathyroidectomy, in the small studies which have been done, has been shown to be superior to just treating with calcimimetics, both in terms of normalizing serum calcium, normalizing parathyroid hormone, and in actually improving the femoral neck bone mineral density. So there's certainly advantages to it. The surgical technique applied, often as physicians, when we refer patients for surgery, we let the surgeon decide what to do with, what sort of procedure to undertake. But with hyperparathyroidism, both in this context, in the context of tertiary hyperparathyroidism, and in the context, for me, with part of what I do is multiple endocrine neoplasia type 1. So in the context of parathyroid surgery for MEN1 patients, we actually play a significant role in what sort of surgery is undertaken. And so our surgeons will not operate on these patients without having detailed discussions with us. So with tertiary hyperparathyroidism, obviously the options tend to be either subtotal parathyroidectomy or total parathyroidectomy with or without autotransplantation. If it's without autotransplantation, then obviously the patient is reliant on vitamin D analogs and possibly calcium supplements going forward. With subtotal parathyroidectomy, what the surgeons will often look to do is they will explore all 4 glands, but they will leave in, if there's a normal looking gland, they would leave that gland in. Whereas with total parathyroidectomy, they will take out all the glands, and what they may do is transplant a small bit of what looks like the most normal gland, but they'll transplant it somewhere else, either in the sternocleidoid muscle or in the forearm. Unfortunately, the issue with that is quite a lot of time, these transplants will fail. And so the patients will end up having to go on calcium and vitamin D analogs anyway. There's no real evidence base to say which form of therapy or of surgery is better. And also there are a few controversial ideas. People do think about things to make, what can we do to improve the surgical outcomes? Intraoperative parathyroid hormone monitoring is one way, that some centers are doing this. To be honest with you, it hasn't really been shown to clearly improve outcomes, because in patients where you get the recommended 50% drop in parathyroid hormone, some of those will then go on to recur, and some will go on to have complete failure of the residual parathyroid tissue. So it doesn't really give you a clear answer. Also, in terms of imaging, sometimes people will do scans to look at whether they can identify which glands are the most affected and where to undertake surgery. Again, because of the recurrence rates and the failure rates, that doesn't, it's not really established as, in any guidelines or anything like that. So at the moment, parathyroid surgery for tertiary hyperparathyroidism will generally involve examining all 4 glands. And so to summarize, like I said, tertiary hyperparathyroidism generally results from prolonged stimulation of parathyroid cells, usually in the context of chronic kidney disease, of long-standing chronic kidney disease. It can have quite significant sequelae, not just on the usual bone, in terms of usual bone pathology, which we talk about with hyperparathyroidism, but also, for the transplant patient's graft, for the cardiovascular morbidity and mortality. And the treatment does need to be individualized, because some patients will respond well to medical therapy, many will not. And if they have got to go for surgery, then you do need to think about what sort of surgery needs to be undertaken. So thank you very much for listening, and happy to take any questions.
Thank you very much, John. Samir is there in the background, but again, thank you very much. Samir, here we go. Sorry, I could not see you in the background, so I thought you might need to do something. Yeah, okay.
I'm here.
Yeah.
So we move on to the cases, Dr. Tariq?
Yes, I think for sake of time, we'll be moving to the cases. Again, thank you very much, John, for a very fantastic and crisp presentation, for a very teasing sort of and quite difficult topic to deal with by clinicians across the board, not only endocrinologists, but including as well renal physician. I'm quite fascinated by what you mentioned about the joint sort of metabolic clinic involving renal physicians. I would like also to take this opportunity to thank Merck, our sponsor, for providing the logistic support for such very invaluable educational event. And also I will extend the thanks to our host, ICOM, who are our partner public relation company. Thank you very much, Ziad and Yasmin. I think, Hussam, there is a sort of a tiny sort of change. You will be second, and the first of the next session on the thyroid round is going to be delivered by Dr. Sarah Ashihri from Saudi Arabia. Dr. Sarah, you will have 10 minutes, including 8 minutes of your presentation and 2 quick minutes for a quick question or questions, but please stay till the end of the discussion session where we will have more and more questions from the audience. So the thyroid round session has been designed in order to get as much as possible of participation from across the Arab world. And as I mentioned, we have 2 presentations from Saudi, 1 from Qatar and 1 from Jordan. And we hope to continue to adopt this tradition in future meetings. Sarah, the floor is yours, and please just mention your affiliation and the other colleagues who are involved with you in the case.
So good evening, everyone. This is Sarah Shahri, a second-year endocrine fellow from King Saud University Medical City. It's my pleasure to be here today, and I would like to thank the organizing committee for accepting my case and giving me this opportunity. So I will start with the case. We have a 39-year-old lady who's known to have a relapsing remitting multiple sclerosis, presented to our emergency room with history of palpitation, dizziness, and sweating, associated with history of diarrhea 2 to 3 times per day. She noticed that her hair became brittle, and she reported that her cycle is irregular in terms of oligomenorrhea. So endocrine team was consulted for abnormal thyroid function test. In regards of her past medical history, she is known case of multiple sclerosis, diagnosed more than 5 years back, which was complicated by history of neurogenic bladder and recurrent urinary tract infection. She failed multiple regimen before, and the neurology team decided to give her almatuzumab. She received the first cycle of almatuzumab 13 months before her presentation to us. She has no history of thyroid disease or other autoimmune diseases, and she has no family history of autoimmune disease nor thyroid diseases. In regards of physical examination, she was tachycardic at a rate of 120 beats per minute with a regular pulse, and she appeared anxious with the peripheral tremor. She has no signs of Graves' ophthalmopathy, and her thyroid examination shows a diffuse enlargement of the thyroid gland. In the laboratory values, you can see that her TSH suppressed at a rate of 0.007, and her T4 was high at a level of 109 with a positive TBO test. And her thyroid ultrasound showed mild enlargement of both thyroid lobe with heterogeneity appearance and hypervascular background in the color Doppler evaluation. In the chart here, you can notice that the first dose of almatuzumab was in November 2019, in which she was having a normal thyroid panel at that time. 13 months after, she started to have increase in the T4 and suppression of the TSH, in which after then she presented to the emergency room. Her thyroid scan demonstrated increased uptake with no focal hot or cold nodule, and which was compatible with the Graves' disease. Our impression at that time was almatuzumab-induced Graves' disease. So she was started on carbimazole and propranolol. She was discharged home with a frequent follow-up. During her follow-up visit, she was doing fine, and her thyroid panel was euthyroid and carbimazole. 6 months after that, neurology team decided to give her another cycle of almatuzumab, and 1 month after the second cycle, unfortunately, she presented again to our emergency room with history of nausea, vomiting, and she was tachycardic at a rate of 140 with respiratory distress. She was admitted to intensive care unit with impression of pneumonia and thyroid storm. Despite the maximum dose of carbimazole and hydrocortisone, propranolol, potassium iodide, her T4 was not improving, and her liver function test was deteriorating. So finally, she underwent total thyroidectomy. And after 3 days after that, steroid were stopped, and propranolol was gradually tapered. She was then maintained on levothyroxine, and she was doing fine. So our talk to date about almatuzumab-induced Graves' disease. As we know, thyroid dysfunction is a common side effect of many treatments that act with a different mechanism, including but not limited to interferon alpha, interleukin-2, amiodarone, lithium, immune checkpoint inhibitor, and tyrosine kinase inhibitor. Almatuzumab, which is an anti-CD52 monoclonal antibody, will induce a rapid and prolonged depletion of both B and T lymphocytes, causing panlymphopenia, which then cause consequent immune suppression followed by a phase of immune reconstruction with restoration of the lymphocyte network, which can then trigger the production of autoantibody against the thyroid gland. This was also observed after hematopoietic stem cell transplantation and with the use also for highly active antiretroviral therapy in patients with human immunodeficiency virus infection. Almatuzumab, the overall prevalence of autoimmune thyroid event after almatuzumab use seems to be from 34 to 41%, with the Graves' disease on the top of the list. And thyroid autoimmunity has been described only rarely when almatuzumab is administered for other causes, such as rheumatoid arthritis or hematological malignancy or transplantation. Suggesting there is no clear reason for that, but some they related to disease-specific or genetic-specific background effects. It has a late and variable onset, occurring from 16 to 23 months after the last dose of almatuzumab. And the total dosage of almatuzumab and the frequency of intervals between the doses does not appear to influence the development of autoimmunity. So based on the 2019 European Thyroid Association guideline on the management of thyroid dysfunction following immune reconstitution therapy, which was targeted the non-endocrinology physician, they suggest to have a thyroid panel as a screening test before starting almatuzumab, and then to monitor the patient every 3 months after, and then even after stopping almatuzumab, they recommend to continue screening for a total of 4 years from the last dose of almatuzumab. After then, the testing should be performed based on the symptoms and the signs of thyroid dysfunction. And the anti-thyroid drug represent the first-line treatment if patient is symptomatic or at high risk, such as in pregnancy or cardiovascular disease, or if the thyroid dysfunction persists more than 3 months. And for the prognosis, it has a more fluctuating course and unpredictable course than the conventional Graves' disease. As you can see in our case, which showed a treatment challenge and the use of more aggressive treatment beyond the standard use of anti-thyroid drug. And until now, there are no clear guidelines on the management of Graves' disease secondary to immune modulator agent or immune reconstitution therapy. And most of the data from a case report or from retrospective data, which was collected from therapeutic trials with no standardized endocrinological input. Thank you so much for your listening, and please let me know if you have questions.
Thank you very much, Dr. Shihri, for a very interesting case. You will have 2 minutes for questions, and I will see whether we have got any.
We don't have from the audience yet.
Don't have, yeah. Okay.
Therefore,
if you could just, yeah, sorry, carry on, Samir.
Maybe our panel, Dr.
Yes.
Pollard, Dr. Ayuk would be interested in directing any questions.
Absolutely, yeah. Okay.
Yeah, so you quite rightly say that the course is more unpredictable. Do you know of any data that are published on, how many of these patients require surgery, radioactive iodine, how that is managed?
Well, there is one trial, the CAM S23, which was, I think, in the UK. They said that there are 32% of the patient only required a radioactive iodine or surgery. Otherwise, all of them, either they have a hyperthyroid state or they convert to a normal thyroid state after the destructive thyroiditis.
Yeah, so I mean, I think what needs to be distinguished here is whether you get alemtuzumab-induced Graves' disease or alemtuzumab-induced thyroiditis. And most of the checkpoint inhibitors and other agents, they induce a thyroiditis, which tends to be self-limiting. With alemtuzumab, you often have Graves' disease, which tends to be not self-limiting, and certainly in my experience can be very resistant to treatment.
Yes.
So I think it's Carla Moran who published the data from certainly Cambridge and another center, and a significant number of them do require definitive treatment, like in your patients. So did your patient have thyroid storm or not?
Well, it was based on the score of Wojciechowski score. She scored 60 at her presentation. It's that thyroid storm.
And how did you treat the thyroid storm?
We started her on, she was on carbimazole. We increased the dose up to 80, and she was also managed with the potassium iodide and hydrocortisone, propranolol, but her T4 was not improving despite all of that. And her liver function test was more than 3 times normal.
Is that why you didn't use propylthiouracil?
What, sorry?
Is that why, because often in thyroid storm, we prefer propylthiouracil because it also inhibits the conversion of T4 to T3.
Yeah, but her liver function was not that.
Liver function. Yeah. Okay. Yeah. I'll stop talking now.
Just a comment to any one of the senior faculty. If the monoclonal antibodies, likewise the checkpoint inhibitors, has got any sort of predilection for any ethnic sort of group of patients, or is it just can happen across the board in all ethnic groups?
I'm not aware that there is a particular predilection. Different agents have different, so different endocrine organs are susceptible to different agents. So ipilimumab will have a different side effect profile to nivolumab, and all these various agents that we use. often checkpoint inhibitors. It is, I cannot stress it enough, it's often thyroiditis, so don't wade in with anti-thyroid drugs or treatment. It is quite often a self-limiting condition that is very different from alemtuzumab.
And so, just like Christine mentioned, with ipilimumab, we see, well, I say a lot, but we see a fair number of patients who develop hypophysitis with it. So, I suppose inflammation of the pituitary gland with that. And in many cases as well, it is self-limiting. And you get actually quite dramatic pictures. You see, you'll find the cellar completely full with optic chiasm compression and patients going blind. You stop the drug, you don't do anything else, and it all just melts away. A few months later, you do another scan and you've just got a normal pituitary gland there.
So there are clear guidelines on how to manage.
Yeah. Ali, you are mute. You want to say something, Dr. Ali Khalil? You are mute.
Sorry, yeah.
Okay.
I would like to say that it has been mentioned clearly that the course of Graves' disease caused by alemtuzumab is unpredictable in the sense that it could take different patterns. But there have been some cases, if I remember, that have described a switch from overactivity to underactivity due to the change in the type of antibodies that being secreted. So you have times where you have stimulating antibodies, at other we have blocking antibodies. And it's different from the thyroiditis that Dr. Christine has been mentioned about. So I wanted to make that distinction.
I think it's a very important point you raise, and I could not see that this patient had their TSH receptor antibodies checked. Of course, most assays don't distinguish between stimulating and blocking antibodies, right. But it would be good to have a measurement of TSH receptor antibodies, and if they remain high and the patient switches between hyper and hypothyroidism, often that will be autoimmune disease that requires treatment, which once again is different from thyroiditis.
Fantastic. I think because of sake of time, we will leave. Any further question, Dr. Sarah Shihri? Thank you so much for a very interesting case. And please stay with us because when we move into the discussion, there might be some questions from the audience. Now I will leave it over to...
The second case? Yeah.
Yes,
we can
Samir?
the second case. We welcome our next presenter, Dr. Hussam Al-Hawari from Jordan, University of Jordan School of Medicine. He's going to talk about a case of thyrotoxicosis. You can start your presentation, Dr. Hussam.
Hussam, you are mute, I think. Dr. Hussam Al-Hawari, you are mute.
Yeah, good evening all. Can you hear me well now? And can you see the slides? Today I'm going to present an interesting case of severe hyperthyroidism. She's a 27-year-old female with recent diagnosis of Graves' hyperthyroidism and secondary hypertension in February 2021. This was an outside facility, not at the university hospital. She was treated with carbimazole, 40 milligram once daily, propranolol, 80 milligram Q6 hours. And since her blood pressure was not controlled on propranolol alone, apparently they have added valsartan, 160 milligram twice daily. She presented to our university hospital emergency room in November 2021 with fever, watery diarrhea, and generalized weakness. In the ER, her blood pressure was controlled, 135. The diastolic was high, 135/95, pulse 130 beats per minute, regular, respiratory rate 16, auto saturation was fine, body mass index was 21.8. She was conscious, alert oriented. She had bilateral mild exophthalmos, positive lid lag and lid retraction, diffuse large goiter with audible bruise bilaterally. Otherwise, her exam was unremarkable. Interestingly, her laboratory results revealed very high T4. It was above the upper detected range, more than 154. TSH was suppressed, dropped but checked and came back later. It was high, consistent with the physical exam findings of most probably Graves' hyperthyroidism, or actually Graves' hyperthyroidism, and especially with the presence of bilateral exophthalmos and bruise. She was on carbimazole, and in her CBC, she had neutropenia. Absolute neutrophil count was 879. We don't have baseline CBC on her since it was an outside facility. Her cortisol was normal. Other labs were unremarkable. So what's interesting in her case was the very high T4 level. We did not dilute the sample since we won't make a difference in her management. So our diagnosis was a case of severe Graves' hyperthyroidism with agranulocytosis due to anti-thyroid medication. She was admitted to MICU, and she continued to have recurrent episodes of sinus tachycardia up to the rate of 180s, and high blood pressure sometimes in 180s to 100s. Management, we've DC'd carbimazole due to the concern of anti-thyroid-induced agranulocytosis. We've started IV hydration, IV beta blockers, and IV hydrocortisone. While in the MICU, 3 days later, her repeat neutrophil count has improved. This could be suggestive mostly that this was carbimazole-induced agranulocytosis. Challenging thing in her case, we were thinking low-dose radioactive iodine therapy versus surgery. When I trained in the States, I had some cases of severe Graves' disease who were intolerant to anti-thyroid medications, but did not have this severe sinus tachycardia and high secondary hypertension. We've tried 5 millicuries of radioactive iodine, like a very low dose, and they did well. We did not even have to redose it. 5 millicuries were enough in case of severe Graves' disease. But in this case, the concern was that she already had sinus tachycardia, hypertension. She could have form of cardiomyopathy. So we were concerned of doing low-dose radioactive iodine versus surgery. Just interestingly, while we're looking up the case with the fellows, also the concern in her case of her developing severe radiation thyroiditis. And in this paper, we've seen there was a complication of myopericarditis. So we were really cautious, even of giving very low-dose radioactive iodine. As in preparing her for surgery, we looked up some articles also since her TRAP was very high. We looked up some articles looking preoperative plasmapheresis. This was a case report, but actually there was a few more cases. They've done plasmapheresis 3 days before surgery. This was a case of drug-induced hepatotoxicity. In our case, it's drug-induced agranulocytosis. But we've done it. So we've decided in total thyroidectomy, we've discussed benefits, advantages, and disadvantages with patient. And her wishes was to proceed with surgery. In addition to previous treatment, we've started her on low-dose solution, 10 drops Q8 hours, cholestyramine, and plasmapheresis, 1 session per day for 3 days. We can see, interestingly, T4 level went down to 59, at least it became predictable. TRAP went down from 20 to 6.6. TSH continued to be suppressed as expected. As we know, it lags behind T4 levels for at least 4 to 6 weeks. So after plasmapheresis, she then underwent successful total thyroidectomy without any complications. She did really very well. We started her on full dose levothyroxine. She's to come to follow in the clinic. I will check her TRAP antibodies just for fun, but as Dr. Bollard said, we expect with surgery, we'll have very good TRAP lowering effect. It's even better than radioactive iodine, which was a concern in her case. If we had this peak in TRAP antibodies, it may even worsen her status, even if transiently. So this is the case. Thank you for listening.
Thank you, Dr. Hussam. Very interesting case. I'm sure there's a lot of learning points here behind this case. I will leave the floor for our distinct panel if there is any questions or I want to raise for the case, including also any questions from audience regarding this case. We'll be very happy to.
Can we remind it what was the white blood cell count?
2.4, with absolute neutrophil count below 1,000, 800 something.
Yeah. I don't know what you think. I think I would not have stopped her carbimazole. I don't think it's a carbimazole-induced neutropenia. If anything, really, the severity of the hyperthyroidism could be a major factor in inducing the drop in her white count. And the management of her hyperthyroidism is essential in this case, because we have seen cases where treating the hyperthyroid case will adjust the count, the white blood cell count. This is my observation. I think the Lugol that you gave her did really work very well in this case. And that was a way to take her to surgery. But my point, I would not have stopped the carbimazole.
But how could you differentiate, Dr. Ali, between carbimazole-induced agranulocytosis, or hyperthyroidism-induced agranulocytosis, which could be life-threatening?
Yeah, the differential would be as the response to treatment. If you treat aggressively with anti-thyroid medication, and you will see a change in the white count, that really the improvement in the hyperthyroid condition will usually associated with the improvement in the white count.
Yeah, well, but she has been on carbimazole for a year since she came to us.
She was on 40 milligrams of carbimazole, right?
Yeah, for at least 1 year. I mean, 10 months.
This is not really a very high dose in her case, because you know that there has been some suggestion to gear your anti-thyroid medication based on the level of thyroid levels that you have. I would have been more aggressive than 40. Definitely, I would have been gone into 60 milligram, even higher. And then now you're telling me the 40 milligram, we don't have any idea how compliant she was also with the treatment.
Yeah, well, at some point she said she was on 80 twice a day, but still she was not my patient prior to her presentation. But she reported a dose of 80 milligram twice a day. So trusting what the patient says, I could not really exclude the rare risk of carbimazole-induced granulocytosis. I could not just take the risk and continue.
I have a comment from Christine.
Yeah, thank you. I agree. I think it's really difficult to continue anti-thyroid drugs with that white cell count. I would feel very nervous about that. So it's very interesting that you use plasmapheresis. I've not done that. So I still think, regardless of whether this was hyperthyroidism-induced, low white cell count, or drug-induced, the right treatment in this case is surgery, because what you need to do is relieve the effect of these high levels of circulating thyroid hormones on the heart here. So I have dealt with a number of cases with significant cardiomyopathy from thyrotoxicosis. And actually, as soon as you take the thyroid out and relieve that excess thyroid hormones, you see the ejection fraction from a heart that's barely pumping goes up from 10% to 70% within hours. So my management here would have been also to stop anti-thyroid drugs, to give iodine, either potassium iodide tablets or Lugol's iodine, give high-dose steroids. I would give cholestyramine. You might want to consider giving lithium, and then get a surgeon to take it to theater. And as soon as you remove this thyroid gland, the patient will get better. So we wouldn't have gone for plasmapheresis. I think the outcome would have been the same. We would have removed the patient's thyroid gland and they would have got better. And I think if you continue anti-thyroid drugs in this situation and the patient dies of fulminant sepsis, you are on very sticky ground.
I would like to comment here. I'm really surprised that, Christine, you didn't mention to use PTU in this case, because that is really, that's where really the effect on the peripheral circulation would be affected. But that's beside the point.
If you have granulocytosis, you do not restart an anti-thyroid drug. You don't
based
change.
Based on your definition, it's not the case of granulocytosis.
It's neutropenia.
That's right. So there's difference between granulocytosis and neutropenia.
But I
agree
would have
that
felt
the
very
treatment,
uncomfortable.
I agree that the treatment, ultimate treatment, they have done the right way of taking her to surgery, because she had a very severe case of Graves' disease. I'm making the point about really stopping the anti-thyroid medication while preparing her for surgery. This is my point. But again, I didn't have the notion that they use even higher dose before, 80 milligrams twice a day, and it did not work. So in that case, yeah, I agree that something has to be done as a permanent treatment.
So in my experience here, the most effective treatment is iodine, low-dose iodine and potassium iodide. That is what brings circulating thyroid hormone levels down, and that is what gets the patient ready for surgery. And like I said, in a medical legal case, if you continue anti-thyroid drugs, I wouldn't like to have to defend that.
Low-dose iodine may even shrink the thyroid in size.
Correct.
It is vascular, so easier access to the surgeon.
It reduces the vascular flow in the
Exactly.
thyroid gland, and that makes because these are very difficult thyroid surgeries. These are very vascular glands.
Exactly.
The surgeons don't like it, and it reduces the vascular flow. So it's a very good treatment. So we've dealt with a few cases here with extremely high levels of thyroid hormones, and actually within 7 days. I always tell them on ITU, give me 7 days, I will have this patient controlled, and it's the potassium iodide that does it.
Fantastic, guys. I think if I may just, for sake of time, we will come back to whatever left from this very fruitful discussion in the discussion section. And again, it gives me great pleasure to welcome another Sarah from Saudi, Sarah Ajami, to present the third case. If you could just mention your affiliation, Sarah, and if you have any other senior colleagues involved in the case with you, please. Thank you.
Thank you very much for introducing me and giving me the opportunity to share my case with you today. I want to just make sure that the slides are clear. Okay, so Bismillah. Today I'm going to talk about a 52-year-old female. She's known to have primary hypothyroidism, underlying Hashimoto's thyroiditis, diagnosed 14 years back, and has been on levothyroxine since diagnosis. Her current regimen is 75 micrograms per day. She presented to the clinic complaining of diplopia and periorbital swelling for 5 months duration. The diplopia was described as shadowing of the surroundings. It was horizontal, binocular, mainly on the left gaze, while both eyes open. And it did resolve when she closed either eye. There's no history of ocular surgeries, injections, laser, trauma, no previous hyperthyroid state or radioactive iodine therapy, and no history of smoking. On physical examination, there was no goiter, bruit, or palpable lymphadenopathy, no tremors or peritibial myxedema, and she had normal deep tendon reflexes. On ophthalmic examination, she was found to have left exophthalmos, as well as left-sided upper and lower eyelid swelling, with limited abduction and diplopia on the left side, and she also had mild punctate keratopathy. Investigations showed a TSH of 3.6 and a free T4 of 14.6, so she was in euthyroid state. TPO antibodies were positive, and TRAB antibodies, stimulating TRAB antibodies, were also found to be positive 500. That was in October. A contrast-enhanced MRI was done for the orbits, showed bilateral ocular proptosis with intraocular muscle enlargement, in particular the medial, inferior, and superior rectus muscles, as well as the levator palpebrae superiosus muscle. The maximum thickness of the muscles was reaching 7.8 on the left side and 7.2 millimeter on the right side. The muscles demonstrated high signal intensity on the T2 weighted images. The optic nerves were unremarkable bilaterally. And the impression was that these manifestations were related to thyroid-associated ophthalmopathy. Ultrasound showed a small heterogeneous thyroid gland with no definitive nodule, and there was no radio tracer uptake by the thyroid on nuclear uptake scan. So our assessment was active, moderate to severe, isolated Graves' ophthalmopathy with a background of Hashimoto's thyroiditis. She was clinically and biochemically euthyroid on levothyroxine. The patient was referred for management to an ophthalmologist to take his opinion on advanced management, including IV pulse steroids and either or with biologics. It was decided that she starts a course of high-dose oral prednisolone which was tapered over a 3-month course. Her diplopia improved symptomatically by the patient 50% after the first month of treatment. She was then shifted to selenium, 100 mics, oral, twice daily with lubricating eye drops. And during her last clinic visit, she had stable thyroid eye disease, and there was no need for further intervention with biologics or steroids. So as we know, Graves' ophthalmopathy is an inflammatory disorder of the orbits, and it occurs in association with autoimmune thyroid disease. Although most patients with Graves' ophthalmopathy have a history of hyperthyroidism secondary to Graves' disease, some are euthyroid and some are hypothyroid, primarily caused by Hashimoto's thyroiditis. The underlying cause is due to the presence of TSH receptor autoantibodies directed against the thyrotropin receptors, which are expressed on the orbital fibroblasts, leading to enlargement of the extraocular muscles and expansion of the orbital adipose tissue. There's local inflammation due to cytokines and infiltration of mononuclear cells and macrophages. The diagnosis is difficult in euthyroid patients and hypothyroid patients. In this circumstance, what could help is obtaining images using CT or MRI, with paying special attention to the orbits, making sure that we rule out other causes of the eye symptoms like an orbital mass lesion. If the imaging is compatible with Graves' ophthalmopathy, having elevated TRAB antibodies would be helpful in making the diagnosis, although the absence of the autoantibody does not rule out the diagnosis of Graves' ophthalmopathy. When Graves' ophthalmopathy is diagnosed, we need to assess the activity and severity of the disease. The activity can be assessed using the clinical activity score extrapolated from the 2021 EU GOGO guidelines for the management of Graves' ophthalmopathy. And the severity can be categorized into mild, moderate to severe, or sight-threatening, depending on the clinical features. And the severity should be assessed to help guide the aggressiveness in therapy, which is also extrapolated from the 2021 EU GOGO guidelines. In regards to the management, there are general measures for all patients with Graves' ophthalmopathy, which includes referral to a specialist ophthalmologist, smoking cessation, and achieving euthyroid state. There are also local measures which lead to relieving the symptoms of the patient, be it active or inactive disease. This includes ocular lubrication. Botulinum toxin can help with the diplopia. Now, in regards to the severity of the disease, if it's mild and active, antioxidant therapy with selenium in selenium deficient areas can be beneficial. But if the disease is severe, moderate to severe in severity, then the first line of therapy is high-dose IV steroids preferred over the oral, either alone or in combination with other immunomodulatory therapy like mycophenolate or cyclosporine. And this is all extrapolated from the management of Graves' ophthalmopathy in Graves' disease. In moderate to severe inactive disease, rehabilitative surgery can be considered. And of course, if there is sight-threatening disease, then high-dose steroids can be tried. If no response, then we should proceed with urgent orbital decompression surgery. So although rare, Graves' ophthalmopathy can occur in patients with Hashimoto's thyroiditis, and awareness of this clinical presentation is important, as early treatment can prevent corneal involvement and blindness due to optic nerve compression. The incidence of Graves' ophthalmopathy in the setting of primary hypothyroidism, Hashimoto's thyroiditis, varied between studies from 2 to 7.5. Most were case reports. 2/3 of the cases were inactive and mild, and they were more likely to occur in patients who had a longer duration of Hashimoto thyroiditis and in the older population. The pathogenesis, again, can be explained by the development of TRAB antibodies directed against the receptors in the orbital fibroblasts. There have been demographic differences. They noticed that the Asian population have less severe manifestation. And in one study, treating the hypothyroidism with thyroxine resulted in improvement in ophthalmic manifestations of a patient. But for most patients, the management is similar to managing Graves' ophthalmopathy and Graves' disease, maybe requiring less aggressive therapy. We still don't have clear guidelines on how to treat the Graves' ophthalmopathy without underlying Graves' disease, so in a setting of Hashimoto's thyroiditis. Thank you, and if anyone has any questions, I would be happy to.
Thank you very much, young lady, for a very fascinating case and very excellent and crisp presentation. Thank you, Sarah. Christine, I'm sure you have got quite a lot to say about this.
Yeah, so you say that we don't know much about, which is true, because it's much more rare that we see it in patients who have Hashimoto. You know, whether that's because they have blocking antibodies to the TSH receptor and actually the pathogenesis is the same, probably. I do think it's important that, you know, because the most important thing here is to keep the patient euthyroid. So making sure that levothyroxine replacement is adequate is very important, because even in the patients who have Graves, who previously had very high levels of T4, you know, if you make them hypothyroid with surgery or radioiodine, it's the hypothyroidism that often drives their, you know, worsening of thyroid eye disease. So that's really very important. I see, because it was in my email today, I haven't looked at them yet, but the European Thyroid Association has just brought out new guidelines on management of Graves' ophthalmopathy. I presume you haven't looked at them either.
No,
I presume that would be
the
pretty.
latest produced was the EU GOGO.
It'd be similar to the EU GOGO guidelines. It's the same author, so I presume it's pretty similar. But it's obviously a very rapidly evolving field with a number of new immune modulatory agents being used. Experience is not that good. They are very expensive, those drugs, and certainly not routinely available in all countries.
Thank you.
Thank you.
Yes,
That's
very fascinating. If I just made to make a comment, when I was in Sarah's boots, working as registrar with the formidable Pat Kendall-Taylor in Newcastle, just in the mid-1990s. I remember I was first introduced to this concept of a switch from blocking to stimulating antibodies. And probably your case might not be a sort of a true Hashimoto. It might just be actually a Graves presenting with a sort of an inverse presentation with blocking antibodies causing hypothyroidism, and then later on the sort of expression has changed again of the you know, clonal sort of cells started actually to attack a sort of a similar sort of antigens located in the fibroblast. But very fascinating. I would like just to mention a case here of interest as well. It is quite actually intriguing to come across a previous case of also Hashimoto, who was treated with levothyroxine, a young lady, and then she was off treatment for around 14 years after she has been on treatment for 14 years. And then she contracted COVID, okay, just last year. And around 3 months after that, she got actually Graves' disease. She presented with eye signs, and her Graves' ophthalmopathy was rather mild to moderate, which settled actually when we control her hyperthyroidism. And so you could see a sort of a trigger, something happened. Was there any sort of specific trigger for that you could identify in this patient?
No, by history, there was nothing that had changed over the past years. No infection or illness within the year of developing the symptoms.
And just a general question, if I may, just to throw, the role of selenium, Christine, Ali Khalil, and the rest of the distinguished faculty. How good, how effective? Because there is some controversy, I think, in some papers, if I'm right.
Yeah, so there was the initial paper in the New England Journal from which I think a lot of the guidance started. I think selenium is a very controversial issue. I'm not the greatest believer, but I think often in patients who have thyroid ophthalmopathy, I don't think we're doing much harm. I know there are some centers who check selenium levels. I think the evidence for that is really quite patchy. And what you need is actually a selenium phosphate measurement, which you can't get. So I don't think measuring selenium helps. I tell my patients to go to Holland and Barrett and buy some Brazil nuts, which are full of selenium. I don't think we're doing any harm, but I think the whole selenium story, both in Graves' ophthalmopathy and in changes in patients with hypothyroidism, is quite patchy, if I'm honest. But I'm happy to be contradicted by my colleagues.
Ali Khalil, any comment?
No, I will not contradict what she's saying, because exactly that's she's saying the right thing. Is that really there is no proof one way or another that really the studies have been contradictory, and the use of selenium overall is not very clear. Now there is more emphasis maybe in Graves' ophthalmopathy, but again, none of the studies really is convincing study. But you think
how often you have seen such cases of switching from a sort of a hypothyroid to a sort of a hyperthyroid, but not in this case. She's not hyperthyroid, but she presented with another sort of part of the spectrum of the general sort of a hyperthyroid state.
So it's very interesting, because I raised my hand because I wanted to bring this up. So this is very anecdotal, but so over the last 2-3 years, I'm seeing far more of these cases that switch between hypo and hyperthyroidism. And I honestly believe that COVID has something to do with it. So when I first wrote the guidance for the European Society on management of thyrotoxicosis in COVID, I said we have no evidence that patients are more likely to get Graves' disease, or patients with Graves' disease are more likely to differently respond. I do think the COVID virus elicits Graves' disease, and I do think the COVID virus, the coronavirus, leads to more of these cases where they switch, because I used to get maybe a handful a year, and I'm virtually seeing 2 a month now where there is switching between them. And there's got to be something in. There is clear evidence documented in the literature, mounting evidence. As you know, the COVID literature changes every day, but there is clear evidence of the link between the virus and setting off Graves' disease, as well as obviously thyroiditis, which is not entirely surprising.
You are dead right, Christine. Actually, we just submitted a paper of a case series, 10 cases of thyroid dysfunction due to COVID. 6 of them actually were Graves. And one of them, the one I mentioned, that she had Hashi before, and then she switched. We just submitted actually last week for publication. Quite fascinating area, changing dynamically. I think for sake of time, I will hand it over to Samir, and I'm sure we would have much to discuss. So young lady, Sarah Al-Ajami, thank you very much from King Saud University. Stay with us because you might have more questions in the discussion. Samir Al-Isa presents
last presentation is by Dr. Abdelmajid from Qatar with the title of Carbimazole-Induced Hepatic Dysfunction. Dr. Abdelmajid, you can start your presentation, please.
Good evening. Can you hear me?
Yes, we are hearing you, Abdul Majid.
Yes.
Go on.
Okay. I'm Dr. Abdul Majid from Doha, Qatar. I'm internist, basically. I'm working at Hamad Medical Corporation. First of all, let me thank Dr. Tariq, who is involved in this case, his case management, as well as preparation of this presentation. And actually, we published this case as a case report, and his contribution was definitely immense. So, secondly, I would like to thank the organizers, the Arab Thyroid Association, for inviting me for this presentation. I have no conflict of interest to disclose. So the case is an unusual cause of jaundice in thyrotoxicosis. Quickly, in the history, 30-year-old lady referred from primary health center. She had yellowish discoloration of the sclera and urine for 1 week. She had low-grade fever and vomiting, 2 days. Also, she had itching for 10 days duration. Review of system, other systems, unremarkable. History, continuing history, she came from Pakistan 2 months back and no history of any sick contact. The important history is she had thyrotoxicosis diagnosed 1 month back from primary health center, and she was started on treatment, carbimazole and propranolol. No history of diabetes, no hypertension. She's married, 2 children, and last childbirth 2 years back. She had family history of hyperthyroidism and no family history of liver disease. Treatment history, she was started on propranolol and carbimazole. No history of any illicit drug use, OTC, herbal or indigenous medicines. No history of alcohol consumption. On examination, she looked well, vital stable. She had a BMI of 20.5. On examination, other findings, she was icteric, no other stigmata of chronic liver disease. She had linear excoriation marks, probably due to the itching, which I mentioned, and she had mild goiter, no eye signs. Other systems, cardiovascular, chest, abdomen, neurology, all unremarkable. Coming to the initial labs, her white count, hemoglobin, platelets, all normal. Urea lights, normal renal function, sodium was 133. The remarkable thing is her deranged liver function. She had cholestatic sort of a picture of hyperbilirubinemia and elevated transaminase. So at this point, the differential diagnosis that we consider definitely drug-induced hepatitis in the top, because she was on carbimazole for last 1 month. And other possibility is viral hepatitis, because she just came from Pakistan, where you can have, there are any endemic areas of hepatitis. Autoimmune hepatitis, obstructive jaundice because of the cholestatic picture, which can be due to stones, strictures, tumors, worms, etc. Now, viral serology, negative. Virus hepatitis A, B, hepatitis C, and hepatitis C, all negative. Other virus, viral serology, again negative. Only EBV, IgG was positive, which denotes past infection. Autoimmune screen, negative. Anti-mitochondrial, anti-smooth muscle, ANA, anti-thyroid, all negative. Ultrasound abdomen, no evidence of gallstone, no signs of cholecystitis. We did a MRI liver because of the cholestatic picture, and it reported no intrahepatic or extrahepatic biliary obstruction. The only features, it was suggestive of severe hepatic parenchymal disease, which denotes viral or drug-induced hepatitis. So these are the labs which she had in the beginning, 1 month prior to the admission. That is when she had first detected to have hyperthyroidism. So the thyroid profile you can see is suggestive of hyperthyroidism, and at that time the liver function was normal. And the second lab, which is done 1 month later, that is 2 days prior to this admission, we can see the thyroid parameters are improving because she was on carbimazole. Now, just to quickly through the literature, there are few case reports, carbimazole induced hepatitis. I'm not going into the detail, just passing through because of short of time. Now, with a working diagnosis of drug-induced hepatitis, she was started symptomatic supportive treatment, IV fluids, antiemetic, hydroxyzine, which is antihistamine for the itching, and cholestyramine and ursodeoxycholic acid for possible benefits of cholestasis. Going to the labs further for the next 1 week, you can see the liver parameters worsening, and predominantly conjugated hyperbilirubinemia peaking at 445, and transaminase also high, but it is remained rather stable. The peak value 170 ALT. Now she was followed, and after 10 days of admission, she started to recur symptoms of thyrotoxicosis, which was expected. She had palpitation, tremor, and sweaty because now she's off medication, carbimazole. And thyroid function is again started to worsen. Further follow-up, next 2-3 days, you can see the liver enzyme now, bilirubin is stabilizing. It's almost plateaued. And the transaminase slightly on the downtrend. We did a nuclear scan, which showed increased radiotracer uptake, suggesting Graves' disease. Now the issue is how to manage her thyrotoxicosis. So we have a patient with known case of thyrotoxicosis, started on carbimazole, developing drug-induced hepatitis. And off medication, she have symptoms of thyrotoxic. So how to manage? So the standard options in front of us are radioiodine is one, and surgery, PTU, or non-thyroidites like steroids, Lugols, lithium, etc., etc. So at this point, we sought the help of endocrinology because I am an internist, I'm not an endocrinologist. So it is lucky to say that we had our Dr. Tariq on board. He is our senior endocrinologist. So the endocrine team stepped in, and for them, in front of them, radioiodine and surgery was these two options they also considered, but radioiodine was rather not feasible because some logistic issues. It has to be requested per patient, and that her risk of thyrotoxic storm. If it happens, we need treatment with anti-thyroid medication. So they also preferred emergency surgery as the best option. So for that and they suggested to increase the propranolol and started IV hydrocortisone as well. So we discussed with endocrine surgeon, which we don't have in our hospital, but we contacted our referral hospital, that is Hamad General Hospital. And endocrine surgeon suggested for a MDT discussion between surgery medicine, endocrine and nuclear medicine. And the plan was to transfer the patient to their side. But unfortunately, you know, the Hamad Medical Corporation, as in many other hospitals facing bed issues, we couldn't transfer the patient next 2-3 days. There was a problem with bed availability. So she was managed in our hospital, and the endocrine team was following. And the next 2-3 days, her liver parameters started improving. And the endocrine team reviewed, and they suggested the plan, cancel the plan for transfer, and they decided to start PTU, propyl thiouracil at 50 milligram TID, and the plan was to gradually try. This was a challenging step. You know, the conventional practice, we don't give once one thioamide is producing side effect toxicity, then the other thioamide also likely to because of the cross sensitivity. But in this case, away from conventional practice, Dr. Tariq and team decided to start PTU with close monitoring of liver function, and the plan was to gradually taper down the hydrocortisone. So the next subsequent few days follow-up, liver function started improving, the bilirubin is coming down, and transaminase also coming down, patient feeling better. And we increased the dose of PTU from 50 to 100 milligram BID. In between, there was 2 days, the transaminase started slightly going up. So we didn't increase the dose further. We kept at 100 milligram BID. And the plan was to consider definitive treatment once she achieved euthyroid status. So subsequent follow-up, the liver chemistry improving, and patient was discharged on 11, that is around 3 weeks of admission. And we followed her thyroid function test that she became euthyroid in the subsequent, after 1 month follow-up in the outpatient clinic. And patient successfully underwent radioactive iodine therapy after 5 months of this admission, that is in October. So a few lines from literature. Hepatotoxicity is rare with thionamides, but it does happen. And PTU, it is, as Dr. Professor mentioned earlier, PTU is more of toxic hepatitis with necrosis, and carbimazole resembles cholestatic hepatitis. A cross reaction between carbimazole and PTU is still a concern when a switch from one to another is considered, despite some reports to the contrary. Higher dose of the drug and older age of the patient are factors for cholestatic injury. So to conclude, carbimazole-induced hepatitis is rare, however, should be considered in patients with jaundice and thyrotoxicosis. Despite reports of cross-reactivity of the two available anti-thyroid medication, in the absence of an alternative management, as in our case, because of, as I said, logistic issues and some other issue. So switching from carbimazole to PTU could be an option. And that finishes the case. Thank you for listening. Any questions? Welcome.
Thank you, Dr. Majid. Very interesting case, and also the steps that would happen to the patient. It probably took a lot of courage to restart patient on a anti-thyroid therapy with the incidence of what happened. Let me just start the questions. What do you think, or even the panel, if they don't mind answering, what would be the mechanism of such therapy causing cholestatic jaundice and then this type of liver damage? Any specific etiology or mechanism?
Literature say it's idiosyncratic reaction, but not of mechanism has been, as far as I know. If anybody else want to comment.
Dr. Bullard, any comment about what's the mechanism?
So the mechanism for PTU is that it's toxic to liver cells and it induces a hepatitis. I think the mechanism of metimazole-induced cholestasis, as this one here, is much less well documented. So I don't think there is a unifying pathogenetic mechanism. Like you rightly say, it's a idiosyncratic reaction, difficult to predict. I agree, it's very brave to start PTU. It was successful. I'm not sure if I would have been that brave.
To make a comment. Thank you very much, Ali. I read your comment. Actually, to be honest, we managed this case the way we managed it out of frustration, because we got nowhere with the surgeons. They were dragging their feet. They were very reluctant. Even they were not keen to come and see her. Sorry to mention this, but we were very frustrated actually by their approach. And they said that, you know, we have to control her hyperthyroidism for them to do the surgery. And that could have been done when she's under their domain, no problem. The other frustrating sort of, you know, component in her management, which led to our sort of brave approach managing her in the way we managed her, was again the attitude of the senior, actually, you know, director of the nuclear medicine department. Again, he refused actually to give her any treatment, saying that she will go into sort of thyroid stone. Plus, there is logistic difficulty actually regarding the availability actually of the radioiodine itself in Qatar. It does come actually in small pulses. So we couldn't have any other alternative because she was actually quite symptomatic, and for her to be started on agents like lithium or even logule iodine might not have been, because with very high dose beta blocker, she was still actually having quite intense sympathoadrenal drive. So I decided just to, you know, initiate PTU and monitor her very carefully. So I have been coming to see her actually every day, and Majid has been monitoring her actually function. Sometimes you do it twice in order just to ensure that we are actually doing. And we in a matter of few days, we were winning, and the patient was getting better. The thyroid hormone were coming down, and she's becoming less and less symptomatic. And after, I think, 5 days or 7 days, she has become much better. So here we go. So sometimes you might have just to think outside of the box, be a bit brave and adventurous, and see what will happen.
I think it's in your character. You're known to be brave. So I have to say that it's, but Doctor, I have a question for you. Is there a reason why you tapered hydrocortisone on this lady? Because in those cases, it has been one of the ways to prepare for radioactive iodine or for surgery. Any reason why you taper down the hydrocortisone?
Yeah, Dr. Majid, you answer that.
Radioactive iodine, actually your plan was to make her euthyroid, and initially then radioiodine plan was a bit later. So as far as I know, we do not continue steroid if she is otherwise improving. Dr. Tariq, you want to add anything?
Yeah, there was another approach actually, because of her cholestatic sort of nature. You know, part of the problem is a sort of also an element of ballooning of hepatocytes, and this will compress, I'm sure you know that, the hepatic sinusoids. And I felt, you know, to give her high dose steroids and then to start the PTU together, and then to taper the hydrocortisone will be the way forward. And actually it worked out, but we tapered it very gradually. Actually, we didn't stop it, you know, suddenly. So I think we gave her around 3 weeks or 2.5 weeks, Majid. I can't remember.
Yeah, let's 2 weeks. 2 weeks.
2 weeks, yeah.
Actually,
but
when
we were winning with the sort of escalating the dose of PTU, and she's becoming much better actually. And I have to say her response, to my amazement, was quite actually dramatic. So she responded very quickly to the PTU, because as soon as we started the anti-thyroid medication, she started to get better. And even, you know, there has been, I'm sure, you know, there might be a sort of multiple sort of elements that have contributed to improvement of her cholestatic problem. And I'm sure steroids has made some contribution to that. But I suspect also the improvement in the thyroid hormone has made a sort of a significant, actually, and eventually it normalized completely.
I wanted to make 3 quick comments, if I may. So switching between anti-thyroid drugs in the case of agranulocytosis is contraindicated in most guidelines because cross-reactivity has been shown. That is much less with hepatotoxicity, and it seems that they have different mechanisms. So still, you know, most people like me would feel nervous, but it is an option. I agree the best option here would have been surgery, but that requires a cooperative surgeon. And if you don't have one, then you're stuck. I would like to add, do not start people on potassium iodide if you're not going to proceed with surgery, because you may well, after 2 weeks, find yourself in more trouble than it's worth when they escape the effect. There was a third thing I was going to say, which escapes my mind now. Yes, so thyroid storm after radioiodine is actually extremely rare. Okay, so in the US, most patients do not get, so in the UK, we pre-treat, most centers pre-treat with anti-thyroid drugs when the patient's euthyroid and then give radioiodine. In the US, that is not done. I was at the Mayo Clinic for 6 weeks. I have seen ragingly toxic patients have radioiodine. They do not go into thyroid storm. It's actually extremely rare. So I think your nuclear medicine department, again, needs to take, now, unavailability of capsules, that's a different issue. You know, there is nothing we can do about that. But the risk of thyroid storm, I think, is very rare. So those were 3 comments I wanted to make.
I totally agree, Christine, with the last sort of part. Actually, the main issue of the guy who's responsible was thyroid storm. And at that time, there was some availability. But, you know, I have actually treated some patients who are very rife with thyrotoxicosis with radioiodine. And that has been done actually in the last couple of years or so. And there has been no problem at all. And they did very well. John, do you have any comment?
Oh, nothing more specific. I think, you know, Christine's covered most of the thoughts which were going on in my head. So,
do you have any sort of, have you had such encounter with difficult cases and the resources has been very much defeating, like what I have here?
May I comment here? I mean, I noticed that you have been following the liver enzymes and the bilirubin. And in such, I had one case actually, and reviewing the literature, most of those cases, even if you give definite treatment, the trend of the liver enzymes and the bilirubin might stay high despite the definite treatment that you give to your patient. So your patient is really surprising that the liver parameters started going down very shortly in the course of the disease. And I think really now short not having surgery, but the patient could have tolerated very well continuing on steroid and getting radioactive iodine treatment with no issues, and without running the risk really of switching to another anti-thyroid medication.
Samir Al-Isa, do you have any comment, Samir?
No, really. I mean, these are all interesting cases. The discussion was great. I'm sure a lot of audience have benefited too.
Okay, I think we will conclude here, and we'll just move into the general discussion session before our distinguished colleague, Dr. Ali Khalil, will make his presentation. I will leave the floor to you. You handle the first few questions. Samir, and then I will contribute to that.
Sure. And actually, there's some of them maybe already been answered in the discussion, so we'll go through them. But I have the first question for Dr. Pollard. There was one question about management of a patient, a pregnant lady with high TRAb, but euthyroid. How would that needs to be managed in these patients with positive antibodies, but being euthyroid?
Okay, so it very much depends whether this patient is euthyroid because they're on anti-thyroid drugs or not. So if TRAb is raised more than 3 times the upper limit of normal, regardless of what the mother's status is, it's about monitoring the fetus. So from 24 weeks, they need weekly fetal heart rate auscultation, they need regular growth scans, and you need to look for a fetal goiter. Like I've said, I've had cases where the mother is actually on levothyroxine, but because high levels of TRAb, you get fetal Graves' disease. And what you there have to do is give anti-thyroid drugs, which will preferentially cross the placenta, so that you can treat the baby's hyperthyroidism while still replacing the mother's levothyroxine, and you may have to increase the dose of levothyroxine there. So very tricky. It's a multidisciplinary approach with obstetricians, endocrinologists, and then the neonatologists need to be on board because these babies are likely to be born with significant neonatal thyrotoxicosis. We've managed a few of these cases, very difficult to manage. But so by and large, the management is based on TSH receptor antibodies. If they are 3 times or more the upper limit of normal, it's about surveillance and then intervention as needed.
One more question, Dr. Pollard. Someone has asked about Graves' disease in the context of having thyroid cancer. Would the thyroid cancer will be more aggressive?
I don't think there's any evidence that it's more aggressive. There is evidence that patients with Graves' disease are more likely to get papillary thyroid cancer. It's not entirely clear what the exact underlying pathogenesis is here, but they are more likely to get it. So when you look at, for example, data on radioiodine following treatment for Graves' hyperthyroidism, there is this increased risk of thyroid cancer. It's thought that that's the underlying disease that's translating through to increased risk of thyroid cancer rather than the radioactive iodine. As far as I know, I have not come across any evidence or documented evidence that this is more aggressive or more difficult to treat. Most papillary thyroid cancer is eminently treatable.
Dr. Ayuk, one question about...
Can I comment here? We did a study, actually, a local study, where we looked at patients with multinodular goiter that with hyperthyroidism, Graves' disease, and people with normal euthyroid multinodular goiter. And then we had like a group of 150 patients in each group. And our conclusion really that the presence of really thyroid cancer is almost the same in the 3 groups, contrary to what really had been said in the other literature. And my belief in this is that patients with Graves' disease don't have higher prevalence of thyroid cancer. But if you have a thyroid cancer coexistent with Graves' disease, the behavior of the thyroid cancer a little bit more aggressive than what you see with patients with single thyroid cancer. The take is, if you have someone presenting with thyroid nodule and you do biopsy and the patient has Graves' disease, the accepted trend here is that they behave a little bit more aggressively than other cases with thyroid nodule.
Thank you, Dr. Ali. Dr. Ayuk, there's one question about patient with CKD. chronic kidney disease, do they need to be only enough to give them activated vitamin D, so 1-alpha, or they need also to be on vitamin D itself? Probably what they believe, maybe it's a cholecalciferol.
Yeah, so I mean, that again is something which we would normally individualize per patient. So obviously, in order to act against the hypocalcemia, the patients need activated vitamin D. So if they're hypocalcemic because they've got CKD, they need activated vitamin D. And we would therefore administer either alpha-calcidol or calcitriol. Now, in these patients, it is still worthwhile checking their vitamin D levels on a blood test, because what we'll be measuring will be the 25-hydroxyvitamin D, the substrate. In some patients, because there's that block at that level, you've got a lot of substrate, you've got a lot of 25-hydroxyvitamin D, but it's not being used to make 125-hydroxyvitamin D, then their actual measured vitamin D levels will be normal. And in those patients, you do not necessarily need to give them calcitriol as well, cholecalciferol as well. However, in many of those patients, because they're CKD patients, and there are many factors in CKD patients which make them prone to vitamin D deficiency, many of them will have low 25-hydroxyvitamin D, and in those patients, it is worthwhile adding in cholecalciferol, so the unactivated vitamin D alongside the alpha-calcidol, because as we know, the vitamin D, inactivated vitamin D, does have effects other than just being a substrate to produce the activated vitamin D. It has effects on muscles, on vessels, and so on. So if the patients are deficient in 25-hydroxyvitamin D, which is our measured vitamin D3, then we will add cholecalciferol to be taken alongside the alpha-calcidol.
And I have one more question, Dr. Ayuk. Someone is asking about relationship between magnesium and parathyroid hormone. What could be the relationship between the two, controlling what exactly?
Okay, so it's quite a complex relationship. And so magnesium is necessary both for the manufacture and the release of parathyroid hormone. So what you'll find is, and that's why patients who develop profound hypomagnesemia will eventually develop hypocalcemia. And that's, that is seen the best model for that is the patients who developed proton pump inhibitor induced hypomagnesemia. So what you find in those patients is the PTH level will be low, but not always completely suppressed, and the patients will be hypocalcemic. So the PTH level, normally you'd expect if a patient's got hypocalcemia, their PTH level will be elevated. So what you'll probably get is actually you have hypomagnesemia. You probably have either a parathyroid hormone level which is either in the normal range or slightly above the normal range, but not high enough for the degree, not as high as you'd expect for the degree of hypocalcemia and hypocalcemia. And once you start replacing the magnesium, then you find PTH starts to be manufactured properly again. It starts to be released properly again. So magnesium is necessary both for the production and the release, the secretion of parathyroid hormone.
Okay, two questions to Christine Pollard. Did you consider plasmapheresis before surgery to decrease her risk of surgery with severe hyperthyroidism? And I will flag the other question to you when you answer that.
Okay, so I suppose that relates to the case. Like I said, I have not used plasmapheresis, but I presume, clearly there is documented evidence that works, and it worked in this case. I have personally never used that, but it's something else to put in my arsenal now if I ever need it.
Yeah, okay. There is another sort of questions related to nuclear imaging. Is the acute thyroiditis nuclear images lag behind biochemical conversion into frank hypothyroidism?
I'm not sure I understand the question.
Neither me.
So I suppose, is this someone who moves from Graves to, you know, where antibodies are stimulating and then blocking, but whether you see changes in the nuclear medicine scan?
Yeah, possibly.
I don't know is the honest answer. I don't think people have looked to do that. So I think a nuclear medicine scan is useful to distinguish Graves from toxic nodular disease and to diagnose a thyroiditis. I'm not sure it helps in this going in the hashitoxicosis, and I think that you're guided by your thyroid function test. Like I said, TSH receptor antibodies are not particularly that useful because they don't distinguish. It's quite difficult to get distinction. You know, certainly here in the UK, we'd have to send them to Germany, to George Kahali, to get stimulating or blocking antibody measurements. And often it doesn't, you know, there's no need to do an expensive investigation like that when, you know, you're guided by thyroid function test and adjust the patient like that. I'm not sure whether Dr. Khalil he's got his hand up. I don't know whether he's desperate to say anything about this.
Yeah, thank you, Dr. Christine. No, actually, my hand was to ask for Dr. John a question. But to answer this question, I think one early sensitive method is to do the ultrasound and look at Doppler activity. And that can predict really whether the patient is going through overactivity or underactivity. It's the earliest and the most sensitive test, more so than the radioactivity in those cases.
Okay.
This is how I usually look. I look at the ultrasound, and the vascularity in the thyroid really is a very guide for me, to guide me one way or another.
There's a question for Dr. Pollard, if you don't mind answering it. So the cases that we discussed, all of them mentioning use of carbimazole as a single dose. Any benefit of dividing the carbimazole or even the methimazole into more than one dose a day?
Generally, there isn't. In my experience, it's meant to be given as a once-a-day drug. So the only time I give carbimazole in split doses is in someone who's breastfeeding, where essentially, you know, you try and limit the amount of methimazole, carbimazole that goes into the breast milk. So if someone, for example, needs 10 milligrams a day, I give 5 milligrams twice a day, once after the first feed in the morning and once after the last feed at night, because that to some extent limits the amount that goes through in the breast milk. Other than that, carbimazole is used because it's a once-a-day drug, so compliance tends to be better. Yeah, so I by and large use it once a day. That's what the pharmacokinetics of the drug support.
Yes. There is one question from Ali Bakir. Would you consider lithium in this case prior to surgery? I assume this question to Dr. Abdul Majid, and I can contribute to that. Majid? Dr. Abdul Majid? Right, okay.
Yes. Please repeat the question, doctor.
Yeah, the question, would you consider lithium in this case, lithium carbonate, in this case prior to surgery, your hyperthyroid case? Yeah, okay.
I think glucose-iodine will do the job. I don't have much experience about lithium.
Right. My sort of, I think we considered lithium as an option, just from the top of my head when going through what sort of options we have. However, I wasn't sure about how quick it will act, taking into account that case being very symptomatic. This is why I didn't actually put it within my first options. I'm not sure about my other distinguished, faculty colleagues. Your experience with lithium in sort of how rapid it does act in order to, control hyperthyroidism.
I use it. I've used it in a number of patients with amiodarone-induced thyrotoxicosis before they go to surgery. Now, I throw a lot of things at them, and what the specific contribution of lithium is, I don't know, is the honest answer. But I have used it, and it seems to, the patients have had a successful outcome. But what the exact contribution of lithium is and how quickly it acts in this situation, I don't know. I think often these are desperate situations that require desperate measures, so we throw everything at them that we think will try and control the patient before we can move to another action. So
I think Karim Miran published some series, if I'm right, several years ago. Karim Miran from the Imperial College. But I can't.
It's not at my fingertips, that paper.
Not in your fingertips. Okay. Right.
So
Ali,
Dr. Tariq, maybe we
Ali
can.
Khalil,
move
do
on
you
to
have
the last-
experience before we conclude?
I have to say, really, I haven't been using lithium quite frequently, and I would not be able to comment on this. Usually, I've used it in few cases where, as Dr. Christine mentioned, when there is really, we try to use almost everything to control the patient. But always, I'm a little bit worried about lithium and the side effect of lithium. But again, this has been described, it works when you use it, but my experience is limited with it.
So I use it short term, so preparation for surgery. So as like you know, because we've entered drugs that we're not actually that used to dealing with, and so I've only used it in short term situations.
Fair enough.
Tamer.
I think we're good with the discussion. Amazing. Thank you everybody for their commitment for the discussion and answering the questions. Thanks all for the audience. Very nice questions. And actually, we wouldn't have the time to fully answer all the questions. There were some other good questions. We thought that maybe they were discussed during the talk, and maybe we thought, and moving on for the further talk with Dr. Ali Khalil might be important also as well. So thank you for the esteemed faculty, Dr. Christine Bollard for their talk, and also Dr. John Ayuk. We really appreciate your presentation. Thank you so much for joining us. Without much delay, we move on to our last presentation for tonight. I would like to present to you Dr. Ali Khalil, who's already been part of the discussion. We're very welcome, Dr. Ali, for being within this esteemed faculty. I would like to mention a few words about Dr. Ali. He's a senior consultant endocrinologist at the Imperial London Diabetes Center in Abu Dhabi. He's the leading physician of the thyroid program, an adjunct professor at Khalifa University at Abu Dhabi, received training in internal medicine at Queen's University, endocrinology at University of Toronto, certified American Board of Internal Medicine and Royal College of Physician and Surgeon of Canada. He's also certified by the ICNO for the thyroid ultrasonography. We would like to welcome Dr. Ali. He's presenting today a talk about euthyrox, a new formulation orchestrating better health. Dr. Ali, please start with your presentation.
Thank you, Dr. Samuel. Let me try to share my screen. Can you see my slides? I hope so.
Yes.
Okay. I would like really to first to thank Merck for asking me to give this talk. And I have to say, I have to disclose that really I'm speaker for Merck. So I'm presenting some of the things that would like me to present, but I have to say also I have some experience with what I'm gonna be talking about. So just for a few words, hypothyroidism, we know it's a very reasonably common condition. And whether we talk about subclinical hypothyroidism or overt hypothyroidism, overt, the prevalence is estimated to be close to 2 to 4% for this for the subclinical. The overt is between 0.2 to 2%. Causes could be caused by some issues primarily within the thyroid or higher up at the level of the pituitary of the hypothalamus. The most common causes of hypothyroidism in Europe and USA is autoimmunity. We're seeing it more frequently now in UAE. Iodine deficiency worldwide is the most common cause. And again, we see it post-treatment with iodine or surgery. And we know that the consequences, if left untreated, myxedema and myxedema coma is one of the issues that we have to keep in mind. Mental issues, lipid dysfunction and their impact on cardiovascular disease, if we believe in such condition, and secondary infertility. And in the case of pregnancy, that untreated can cause harm to the unborn child. And then the goal of the treatment in hypothyroidism is usually amelioration of the symptoms normalization of the serum TSH secretion, reduction of the size of the goiter if present, and avoidance of overtreatment, especially by inducing iatrogenic thyrotoxicosis. Now, the main treatment is with levothyroxine, which is an isomer of it's a synthetic isomer of the normal thyroxine that normally endogenously is secreted. It's made of tyrosine molecules, which are including 4 moieties of iodine. The levothyroxine has been really found and produced by different companies to address the issue of hypothyroidism. Now, the one point that we have to keep in mind that as a treatment, levothyroxine is considered as narrow therapeutic index drug, which means that any changes in the minimal changes in the thyroid replacement can lead to either toxic effect on the high level or low level. So if you treat, so you make it changes that can lead to hyperthyroidism. If you under-treat the patient by minimal amount, you can lead to underactivity. And that's the reason over the last years, there have been several countries that have required that to tighten the potency specification of levothyroxine sodium products. And the leading countries for this started in the US and in France, and subsequently other joined in, like in different part of South America and the Far East. And the reason why it's they felt that the reason to tighten the treatment is that as I mentioned, any variability in the dosing can lead to toxic effect, and that the levothyroxine product that really present within the product itself are variable in content stability profile. For instance, the active ingredient of levothyroxine sodium is sensitive to heat, moisture, oxidative conditions, and that's why you have to preserve the medication under certain condition. And then when there is some degradation of the product due to overexposure, like say for heat or moisture, that may lead to overlapping dosing of tablet strength when you're using it, even with doses that differing by only 10%. And the consequence for this is that that will lead to irregular TSH level over a long period of time and can lead to negative clinical consequences. So that's why the idea is that precise dosing over the long term is quite critical in the treatment of patients with hyperthyroidism. And then better control is essential, especially in certain groups like pregnant women, thyroid cancer patient, if you want to deal with oversuppression, if they are high-risk thyroid cancer patient, elderly, you trying to, when you're trying to not to overtreat them and to take into consideration the level of changes in TSH with aging, as well as the pediatric population. So that's why those most companies that have been especially led by the FDA, they have been trying really to make certain that there's reproducibility in the way the bioequivalency as far as really the thyroid product are concerned. And then for this reason, Merck leading the path in this directive, they tried to change some ingredient in the thyroid pill itself. So for instance, they changed lactose to mannitol, okay, to enhance the product stability. And they added anhydrous citric acid to enhance the stability of the levothyroxine over time. So they ended up with a product that's lactose-free, which is good for some people who have some lactose intolerance. But they felt that really the other components have to remain the same, which include like magnesium. You have some other starches that present there, and some stearic acid, which were kept unchanged. And in their mind, that would lead to increase in the stability and the potency, maintain the potency of the drug. Now, based on this, I felt that really I have to highlight the impact of such changes on the pharmacokinetics of the levothyroxine formulation. And for your knowledge, most of you, without realizing, most of your pharmacies now have switched to the new formulation of Euthyrox, without you noticing that this has been happening. The way I noticed this is that for some period last year, there has been some shortening in the availability of Euthyrox. And the reason why was, we were told that was due to some shipment delay, but the main reason why they were really preparing for the switch to the new formulation. And I was surprised at our pharmacy, they were giving patient 100 microgram of Euthyrox, complementing it with 25 microgram with Synthroid, and mixing really with different agents, whatever they have available in the pharmacy. Now, as a question overall, do you think that really so tiny changes in the ingredient, not in the active component, which is levothyroxine sodium, would have any impact on the pharmacokinetics of the drug? Your answer might be probably not. That's what maybe would be the first impression. But I might take you really to a few years back when the FDA noticed some issue with phenytoin. The one company decided, because of lack of supply of calcium carbonate, that they want to switch to lactose. And within the year, they detected a high number of really phenytoin toxicity. And the reason why was lactose making the active ingredient to get into the cell very fast, and then to increase the bioavailability of the drug. And so making changes have to be looked at with some criticism, and be aware that you have to follow your patient a little bit more closely. Having said this, the FDA decided that we have to take into consideration the bioavailability and bioequivalence of any drug that really will be added to the market. And for the purpose of the talk, let me remind you what bioavailability is. Basically, it's defined as the extent and the rate to which the active drug ingredient or active moiety from the drug product is absorbed and becomes available at the site of drug action. And this curve, it can show you the absorption of, let's say, one drug. Like once once the drug is absorbed, you have to take into account that not most of the drug is absorbed. In the instance for T4, between 40 to 80% of the drug is absorbed. So it doesn't get 100% to the GI tract. It has to go through the venous portal system, gets into the liver, gets partly extracted until it gets to the blood again, where the measuring the concentration of the drug at that point will reflect the active moiety that reached the blood and will be available for the action of the medication. Now, one way to look at this issue is to look at the C maximum, which is the maximum achieved in the blood after the drug being absorbed, and the area under the curve, really in this case. So that would give you an idea of how much really has reached the circulation and became available. So that's what bioavailability is. Now, bioequivalence is when you have two drugs and when you compare those two drugs. So you have to look if really the two drugs have identical active ingredients and they have the same bioavailability when they are given at the same molar dose under the same similar condition. So if you look here, we have two curves, one in blue and for one drug, and then one in red for the second drug. And we see that the Cmax for the two drugs very close, and the area under the curve are very similar. So those are, you can consider them as bioequivalent because they are achieving the same Cmax and same area under the curve. Now, the other point that really we have to keep in mind, and the FDA has put emphasis on it, is the two terms, potency and efficacy. So what's potency? Potency is a measure of drug activity. It shows you from the time really the drug gets into the blood, how much medication, if you take this in the x-axis, the drug dose, and the y-axis, the response, how much of the drug will be needed to achieve the Cmax, have the maximum concentration. So if you take drug A versus drug B, the amount of drug that needed to reach the half Cmax is better for drug A compared to drug B. It's quite obvious. We're needing less amount of drug for in the case of A than B. But if we look at the maximum efficacy, maximum concentration achieved, which is represented by the efficacy, we see that drug A is more potent, but less efficacious than drug B, because the efficacy is basically will be reflected in the y-axis, and then the potency will be reflected in the x-axis where the dose is being considered. So having put some definition, if we look at the T4 formulation, in 2003, the FDA came up with that any drug that really has to come to the market, because there have been some generic formulation that trying to get on the market, they found that there is discrepancy between one drug produced by one company compared to the other company. They felt that the FDA defines an LT4 formulation as equivalent if the 90% confidence interval of the difference of the pharmacokinetically derived area under the curve, the difference between those two curves for the AUC, and the difference of the Cmax, the maximum concentration achieved of serum T4, fall within 80% to 125% of a reference product when a comparable dose is administered to healthy volunteers. So this was done on healthy volunteer, and the dose that they use is one single dose, was 600 microgram. And so after the administration of 600 microgram, different in time interval, they took blood concentration and they measured T4. And this is one of the reasons, actually, because they looked only at T4, that the American, the ACE and other association, they had some objection because it did not really look at the biochemical component that really will reflect on the action of T4, which is TSH. And they, for some time until now, some physician, they request that the brand medication should not be switched to a generic form of medication. Now, and again, to make it even tighter, they came up in 2007, the FDA came up with another requirement that the T4 preparation should maintain their potency within 95% to 100% of their stated potency until the expiration date. So within the shell life of the T4 preparation, there should be this, the range should not be exceed a difference more than 5% from the expected potency until the expiration date. And that they revise it from prior requirement of 90% to 110% to their shell lives. And but that's really nice. The company will tell you we made changes, but again, how to really prove that really what they've done is not associated with consequences. One, they can put it into the market and then ask you really to follow the patient closely and measure thyroid indices every 6 weeks until to see if the patient is stabilized on the medication or not. But really, before they do that, they have to do what we call bioavailability study, bioequivalence study, which consists of basically it's a 2-period crossover design studies where they use 2 formulations, one the new drug that they want to put on the market compared to a standard one. And they use a healthy subject, they randomize them into 2 equal groups. And then there are 2 periods. For the first period, each member of one group receive a single dose of the test formulation, and each member of the other group received the standard formulation. Then there is a washout study, and then the medication are switched over, and then the results are calculated. And in the from the study bioavailability studies that some of them that were carried with the through the request of the company, they found that actually the stability of the new formulation is very well maintained and actually better than the old current formulation. And that when they looked at temperature effect, humidity effect, and climate zone changes, they found that really Euthyrox, the new formulation, had a shelf life of 36 months in all countries, which is equal in among all zones, whether you consider zone 1, 2, which is a climate zone, or 1, 2, 3, 4 in all zones. The shell life, the shell life was maintained at 36 months. Now, when they did, and they carried on other studies looking at the bioequivalency of the old formulation versus the new one. The same type of experiment design I mentioned before. So here you can see that in this here you have total T4, and over a time period they used the new formulation in red and the old formulation in blue. And what they did here, they used 200 microgram tablet for a total of 600 milligram, the dose required by the FDA. And they looked at the changes in the total T4 over time. And you could see there's no much difference between the new formulation and the old formulation. Now, when they did what they called proportionality study, they took like different formulation, 50 microgram, 100 microgram, and 200 microgram, and they lumped them for each to get the total dose of 600 microgram. Again, they didn't find too much difference as far as really level of T4 are concerned. And here they looked at the arithmetic mean of plasma total T4 versus time following the 600 microgram, as I mentioned, or reference in black for the levothyroxine old formulation. Having said this, when they looked at side effects, one beside they found that there is a safety profile that's similar to the old formulation, which is headache being the most common but non-severe event. And when you look into blue, that's the treatment emerging adverse event, like anything that's happening after starting the medication or after the medication was stopped, versus in the old formulation versus the new formulation. And basically, for both of them, they found that really there was no major difference between the old and new formulation as far as safety data for single dose is concerned. When they did look at different doses of using 50 microgram, 100 to 200 microgram, the safety profile was the same when we looking at a proportionality point of view. With this, they came up with and then to make things easier, they advised really that they kept the same 11 different dose strength that they used from 225 microgram to 200 microgram. And then they kept the same shape, like the old being white and the new almost the same shape, so people will not get confused. And they again advised to use it once a day to support patient adherence. And then their conclusion is that basically based on this, that the stability of the drug was maintained, The potency was again improved, if anything, compared to the old formulation, and they felt that Euthyrox can deliver a more exact dose to patient. So hence, individuals receive more reliable and consistent levothyroxine dose according to their medical needs, and that will help to reach euthyroidism within normal tissue duration and maintain the euthyroid state. And with this, this was my last slide. And again, without, as my final point conclusion, irrespective really whether really, and I have to say, the change has been done very smoothly in our clinic. We haven't noticed really major changes in the way that really flagrant results that really required any specific attention. But in any case, I think we are in the obligation to monitor our patient to make certain that really we repeat the tests in 4 to 6 weeks time, to make certain that really the level that we would like to achieve as far as TSH is concerned is well preserved. Thank you very much.
Thank you, Dr. Ali. Very nice presentation, excellent review about the new formulation. It's been a new issue with the formulation introduction in the Gulf. I think we're going synced here in the Gulf states in terms of the timing of introduction of the new formulation. And I had several calls from my patient asking me about comparing the older package with the new package and asking me whether the medication has changed or not. So thank you. Well, Dr. Tariq, maybe we can take some questions from audience.
Yes. Yeah, absolutely. I think I have actually, liaised with Christine. She realized that there are some burning questions she would like actually to handle. So I will give her this opportunity to handle a few of those, because roughly we are moving actually now into exactly 3 hours since we started. And before that, yes, I would like to thank again Ali Khalil for his immense contribution to this activity. Thank you very much, Ali. I enjoyed very much your talk. And just I would like to flag a question at you, being in private practice, because here we are not very much conscious in our institution regarding the cost. Is there any major difference cost-wise between this new levothyroxine formulation
according to our pharmacist, there has been, it's always, like we're private, but not so much private actually, because we're semi-private. Yeah, and then all the dealing is made through our supply chain. And they made certain to get the same type of arrangement as far as payment is concerned. So according to our institution, there has not been difference as far as payment is concerned.
Christine? You are mute, Christine. If you could just, yeah. Thank
Sorry.
you. All right.
It's even later for you. I see there's a question on maximum dose of carbimazole. So I don't think there is such a thing as a maximum dose. If patients need more than 60 or 80 milligrams, that's almost invariably because they're not taking their tablets. And so I have given up to 100, 120 milligrams, but I know that it's highly unlikely that the patient is taking that. If patients need such high doses, you really, really need to consider other treatment options, i.e. radioiodine or surgery. I think radioiodine is the best treatment for most patients. And certainly if patients need such high doses, but is there a real maximum? Probably not. But if a patient needs 80 milligrams or more, you need to do something else, or the patient isn't taking their tablets.
Thank you very much, Dr. Christine, because actually that's the point I tried to make earlier, that when you're dealing with a patient requiring very high doses of carbimazole, compliance is really a major, major factor. And actually, Dr. Ali Bakr is one of the attendees today, and myself, we have shared a similar patient recently. The patient required up to 140 of carbimazole. young girl, and then we switch her between both of us because really seeing two different people sometimes make things clearer. And ultimately, we came up to the point, and she's now controlled, but the major issue is compliance. And most of the time, that's the major issue.
I fully agree. Glad we are agreed. There was something else here. So there's a few questions on hypothyroidism. I think maybe I will leave those because that wasn't the purpose of the talk today. So patient with Graves' disease not responsive to 18 months anti-thyroid drugs, underwent thyroidectomy, still high levels of TRAb. Is there any clinical significance of the continuity? So I think yes. So certainly we see patients present with Graves' ophthalmopathy, sometimes after radio, in a number of cases after radioiodine, after surgery. So I do think they have a clinical significance. I would only continue to measure them if there is a clinical indication. For example, if that patient then comes to you with significant eye disease. I think after total thyroidectomy, what you're aiming for is to get levothyroxine replacement as well controlled as possible. So if this patient becomes pregnant, it has implications, and if this patient has thyroid eye disease, it has implications. I think. I don't know if other panel members have any other thoughts or things they want to mention on that. I'll take it as no. Someone asked about GCSF, so I think that's a good point, and I didn't raise the point in the patient with agranulocytosis. I do use GCSF in that situation. It very much depends on whether the patient is truly septic or not. So, and often it requires a discussion with the hematologist. I think even though we had a bit of disagreement how exactly we would manage this, I think if you have true drug-induced agranulocytosis, often it can be quite resistant, and in those cases you do need GCSF, and that actually lends support to my esteemed colleagues' opinion that maybe it wasn't drug-induced agranulocytosis because it did respond very quickly after stopping the anti-thyroid drugs. And the cases I've seen of profound drug-induced agranulocytosis, it can be very difficult. And often it takes more than a few days for the white cell count to recover, and they do, certainly when they're septic, I do use GCSF quite regularly. How do you differentiate between carbimazole and propranolol-induced agranulocytosis? I think carbimazole-induced agranulocytosis is more common. If you're worried about propranolol-induced agranulocytosis, use a different beta blocker maybe, but I think by and large it will be carbimazole. And how do you know? You look at the response to your various treatments, and actually hopefully you will proceed with because most of these patients with true agranulocytosis, they need a thyroidectomy, and hopefully you can then stop both drugs, and then the issue should be solved, so it's no longer an issue. Repeatedly suppressed TSH with normal T3 and T4, other pituitary hormones normal except for TSH. Is there an other unknown thyroid hormone other than these? I don't think so. I think that's a fairly common situation of subclinical hyperthyroidism, which is often mild toxic nodular disease, maybe mild Graves' disease, and the investigation is doing, in my hands, TSH receptor antibodies and a technetium scan. And then depending on the level of TSH suppression, the general state of the patient, particularly cardiovascular, osteoporosis and symptoms, decide on treatments. And I think that links to the next question, which is guidelines regarding treating subclinical hypothyroidism. There is less on subclinical hyperthyroidism. Yes, there is. We don't have any we don't have any trials of management of subclinical hyperthyroidism. I wish we did. We don't. The evidence is very much based on retrospective study. Most of the evidence of treating subclinical hyperthyroidism is in patients aged over 65. In a nutshell, patient over 65 with a TSH that's consistently below 0.1, I consider treatment. Younger patients, if they have cardiovascular disease or symptoms or osteoporosis. Patients with a non-fully undetectable TSH often don't require treatment. Always make sure that this is a consistent finding of a suppressed TSH. Do the further investigations, and certainly in elderly people, make sure it's not due to other reasons or it's not due to non-thyroidal illness. I think that's probably, I may have forgotten some of the questions.
I think there is one delegate mentioned something about COVID and hashitoxicosis. So you elaborated briefly on that. If you could just mail it your contribution.
So, you know, I mean, it's anecdotal evidence. It's not documented evidence. You say that, you know, you've got a case series published or ready to publish. It's my anecdotal experience that I see more hashitoxicosis with COVID. I see more Graves' disease since we've had the COVID pandemic. I see more hashitoxicosis. And I think it is well possible that the coronavirus does something to the levels of antibodies. That is unsurprising. We know that viruses play a role in the pathogenesis of these diseases. Other viruses, Yersinia, other viruses have been implicated, and there's no reason to think that the coronavirus doesn't. We know that you have the receptors for the coronavirus on thyroid cells, so it is all very well plausible. But I don't have, you know, this is not by no means documented evidence, nor do I have any sort of proper scientific studies to look at the exact pathogenesis of this.
Yeah, I think the interesting feature of it, Christine, if I may to mention, is that we realize that there is a sort of a bimodal distribution. You do see a lot of abnormalities of transient thyroid dysfunction with acute illness. And few months after that, you do have actually a rebound, whether, you know, Graves or whether it is just thyroiditis culminating either in complete recovery or permanent hypothyroidism. And we realize this in our feast of cases. So it's quite.
Also, you have to mention that really we have also post-vaccination thyroiditis.
Yes, that's true.
Yes, really, we have seen really a large number of cases now lately, irrespective of the type of vaccine. And this is due to the excipient that are in the adjuvant in the vaccine itself.
Exactly. I'm not aware of clearly documented vaccination-induced Graves, but I'm aware of vaccination-induced thyroiditis with all the different vaccines that we have.
Right.
I am updating the European guidelines in the next couple of weeks. So I will do all my homework, and hopefully all the evidence will then be culminated in those guidelines.
Thank you very much. I think because of sake of time, if my co-chairman agrees, we had a very fantastic educational session, and I would like to thank our esteemed faculty. Thanks very much, Professor Christine Pollard and John Ayok from Birmingham. Thank you very much, Dr. Ali Khalil from Abu Dhabi, and thank you, my co-chairman. And I would like also to pay tribute to our very excellent 4-case presenter from around, you know, the sort of Arab world. Thank you very much, and looking to see you again in future webinars. And thank you again, our host, and thanks for Merck for making this actually evening quite possible. Thank you, everybody, and everybody has a good night. Thank you. Bye-bye.
Bye.
Thank you, Tariq. Goodbye.
Thank you, John. Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone. Goodbye, everyone.
Bye.
Thank you. Bye-bye.